with you. I am Dr. Professor and Head of Department in Sola Medical College. Along with my team, we will have great 3 days of scientific tour where we will learn almost all the rules and regulations of the cadaveric dissection. 1.
Radiology, CT and MRI. 3. Some of the decision making in how we have to investigate perforation, cholesteatoma. If you see glomus, how will you proceed in these patients? So we will discuss each and everything as far as possible within these 2 days. So we have Dr. Chaitri Shah. She is Associate Professor in Department. Dr. Darshan Parikh. Dr. Nirav, he is Assistant Professor, both are Assistant Professor. All my team, 3rd year, 2nd year and 1st year residents. So in these 2 days, while hands-on, no one will stay alone. There is always one person behind them to assist them, to mentor them for the cadaveric dissection. So we will start. Still some participants, we are waiting for them. But before starting the cadaveric dissection, we will start one PPT regarding the whole basic idea behind this cadaveric dissection, one thing, and second thing, CT scan of this bone. So thank you very much. So first we will see how we will proceed in first 9 to 2, these 6 hours, and tomorrow we will have one endoscopic anatomy, second radiological in detail, CT and investigation of deaf patient. These 3 main topics we will discuss tomorrow. But today first I will. Abiga? Okay. I have to sit there. મારે ત્યાં બેસવું પડશે. Temporal bone. In these 2 days, we have to just almost again how to read temporal bone, how to investigate the patients, how to proceed for the surgery, what are the role of medical management. All these things we will cover in these 3 days. ત્યાં બેસવું હોય તો ત્યાં બેસવું. PPT. Start it. Complex temporal bone. Why it is complex temporal bone? What is the main reason behind it? Why we are worried when we are doing ear surgery or any other surgery of ear pathology? What are the structures?
Related to all the vital structures.
Which vital structures? So very important structures are, one is facial now. dura, sinus, jugular bulb, sigmoid sinus as well as internal carotid artery, and apart from it oval window and round window. So that is the outlet of the aortic capsule in the middle ear, medial wall of the middle ear. So we are worried about all these structures which we have to see in tympanoplasty as well as ear surgery. So in temporal bone, if we just after PPT, I will again teach this temporal bone. But in temporal bone, we have 5 parts. One is tympanic, squamous, mastoid, petrous and styloid. Now which bone? Tympanic bone forms. Tympanic bone forms. So tympanic bone forms the external auditory canal as well as some part of lateral wall of middle ear cavity. Now whenever we are talking about the anatomy on dissection or on the bone, we have to just talk like this: from medial to lateral, superior to inferior, anterior to posterior. Clear? So from petrous apex towards the mastoid process, that means medial to lateral. From superior, this is squamous plate, from superior towards the styloid process, and from zygomatic process to the posterior end of, that is sigmoid sinus. So that is anterior to posterior. So every structures that we will discuss in medial to lateral, superior to inferior and anterior to posterior in relation to the surrounding structures. So tympanic bone forms the entire external auditory canal. If you see the external auditory canal, it reaches medially and it gives notch of Revinus because bone is deficient superiorly. So inferior part which forms the part of mesotympanum, it lies between the anterior posterior tympanomalleolar fold and inferior annulus. So this is mesotympanum. Part below the inferior annulus is hypotympanum and part above is epitympanum. If we see the petrous bone, it forms the medial wall of middle ear cleft. Medial wall of middle ear cleft means medial wall of eustachian tube, medial wall of the middle ear cavity, medial wall of attic, medial wall of the editus, medial wall of entire mastoid antrum. So this part is formed by the petrous bone. So we talk about tympanic bone, petrous bone. Now squamous bone. This is squamous bone. This squamous bone, it forms the zygomatic process, roof of the eustachian tube, roof of the middle ear cavity, roof of the editus and roof of the mastoid antrum, which is known as tegment. So tegment antri, tegment tuberi, tegment tympani. So these are the tegmental wall which separate the middle ear cavity from the middle cranial fossa. But not only the squamous part of the temporal bone forms the tegment, but laterally formed by the squamous, medially formed by the petrous bone. So tegmental wall is formed by two bones. One is squamous bone, other medial part is petrous bone. Again I will remind you, petrous bone forms the medial wall of the middle ear cleft. Again, this petrous bone, as it forms the tegmental wall, it forms the medial wall. Again, it forms the inferior wall of middle ear cavity. So if we see the lateral wall of the middle ear cavity. It is formed laterally by the tympanic bone, medially by the petrous bone. So this way tympanic, squamous and petrous bone, they articulate with each other, they form the part of the middle ear cavity. Still how many participants are? 18 minutes. So yeah. So I start with this otologist. All these otologists, they work hard, persistently hard work during their life, and that way they make our life easy. Because he described that why our temporal bone is so much difficult and complex, because if you see that very tiny structures, it is present in the temporal bone with great variability. If you have sigmoid sinus, if you see sigmoid sinus in one patient, it is always differ from the other. Even in one individual, both sides, sigmoid sinus, jugular bulb, facial nerve, even dural level may be different if you see or compare on the CT scan. So in temporal bone, important structures we will discuss not only on bone, but here this is lateral surface, and in lateral surface, pointer, okay. Here you can see our tympanic bone. This is tympanic bone. This is zygomatic process, superior temporal line, it goes posteriorly like here. So this squamous bone, entire squamous bone, it forms the lateral wall of mastoid, lateral part of mastoid, one, and tegmental wall of the entire middle ear cleft, and roof of the entire middle ear cleft, one thing. Here you can see the styloid process is not here exactly, but this is the vertical part of the squamous bone which forms the lateral wall of the middle cranial fossa. Now this superior temporal line is important. Again, the junction between the tympanic bone and mastoid bone, that suture is important. Same way tympanic and squamous suture is important. We will discuss it again in the dissection. Second thing, this mastoid process, pneumatization of mastoid process is very much important. Cholesteatoma, it spread fast in case of pneumatized bone rather than diploic or sclerotic bone. Now this is internal part of the temporal bone, where we can see this entire petrous bone, along with, you can see this is internal auditory meatus. From this canal, it is 1 centimeter in length, and from this canal 4 important structure is passing from the main center to the ear cavity, that is facial nerve anterosuperiorly, superior vestibular nerve posterosuperiorly, cochlear nerve inferior to the facial nerve, and inferior vestibular nerve inferior to the superior vestibular nerve. Along with that, cingulate nerve also is present in the internal auditory canal, and with that we have vascular supply, that is, yes, labyrinthine arteries. So this is internal auditory canal, this one, this is petrous apex. If we see the petrous apex, it is always pointed medially towards the this is sphenoid bone, and it articulates with sphenoid bone anteriorly and occipital bone posteriorly. As it articulates with these two bones, there are important structures in relation to this anterior surface of the petrous bone and posterior surface of petrous bone. If we see here, most important line overhang is superior arcuate eminence, which is 85% of cases. This elevation is due to superior semicircular canal, and medial to it over the superior petrous line there is a superior petrosal sinus. Now here there are trigeminal cave, one thing, horizontal internal carotid artery, two. Parallel to superior petrous line, there are two more parallel line, that is greater and lesser facial hiatus for greater and lesser petrosal nerve, which enter into the pterygopalatine as well as infratemporal fossa. We will go fast. In posterior wall, you have here opening of the internal auditory meatus. Now lateral and superior lies the subarcuate fossa. Lateral and inferior lies the opening of endolymphatic sac, which is covered with dura. So important structure in the posterior part is extreme laterally is sigmoid sinus, extreme laterally sigmoid sinus. As we go medially, superiorly lies the subarcuate fossa, inferiorly lies the operculum, which covers the endolymphatic sac with the dura, internal auditory meatus, which has four important 7th and 8th cranial nerves with blood supply. Okay. Now next. This is the posterior and inferior part of the temporal bone. If we see the posterior part, this is the posterior part of the temporal bone, and most important structure is sigmoid sinus. Now there are so many other approaches, retrosigmoid approach, middle cranial fossa approach. These structures you have to identify what is the limit of it, tip, dural and sinus limit, because on that basis we have to define the border of cortical, define the border of the retrosigmoid structures. In inferior aspect, we can see jugular fossa as well as carotid opening. Jugular fossa is lies in the floor of the middle ear cavity, and many a time we elevate the tympanomeatal flap in case of tympanoplasty, and suddenly we see if our instrument is touching to this dehiscent jugular bulb in the hypotympanum, if it is present in the middle ear cavity, then what happens? Hemorrhage is first during elevation of tympanomeatal flap it occurs. So we have to take care that while elevating the annulus inferiorly, we have to take care two structures. Posteromedially is jugular bulb and anteromedially is carotid. If there is a dehiscent carotid elevation inside the middle ear cavity, there is a pulsatile or tinnitus, patient is present with tinnitus and you can see pulsatile swelling inside the middle ear cavity. Any pulsatile structure in the middle ear cavity, we have to think about two things. One is internal carotid artery, second is glomus tympanicus. Next, this is bone of neonate where mastoid process is not developed. So we are keeping straight incision or away from the mastoid tip in case of patient less than 2 years. So here we can see mastoid process is not developed, and that's why stylomastoid foramen we can clearly visualize on the lateral surface. Next, all these things we will discuss in our cadaver. This is removal of entire lateral wall. So here we can see this is body of incus, short process of incus, long process of incus, malleus, manubrium, this one is chorda tympani, this is pyramid, this part is facial, this bulge, this bulge is lateral semicircular canal, and this is part of hypotympan oval window with two crura. You can see here, it is clearly seen, and round window. So all these structures we will see in the dissection. Under same picture is here. This is medial. It is also known as surgical wall of the middle ear cavity. Medial wall is also known as surgical because very important structure. See, this part is tensor tympani, cochlea formis. This entire nerve is facial nerve, pyramid. All these structures we will describe in the next our cadaveric dissection. These are the operating setup for any surgery. So what we should have: one, patient's placement, preparation of site, surgeon cella. These are the points. This we will discuss on Sunday in surgeries. So next, there are certain rules for the dissection of the temporal bone, because why we are worried, why you are coming here for the dissection, specifically for the facial nerve, dura, sinus, carotid and jugular bulb. Before touching any patients, we are always worried about the facial nerve. Even in tympanoplasty, we are worried about the facial nerve, where the chances of facial nerve paralysis is very less, even though we are worried. So one should have detailed knowledge of facial nerve and all these surrounding structures. Please come forward. So anatomical knowledge. Second thing, CT scan. CT scan is required specifically for anatomical variations. Low dura, forward sinus, facial nerve variations, along with some of the high jugular bulb. If there is a high jugular bulb, bone is dehiscent or normal. All these things we can see in the CT scan. Next, knowledge of equipment. We all have drill system, suction, everything, but how to use it on the patients? How to use two hands with three-dimensional vision in the microscope, that is most important. So we have to make a roadmap for each and every surgery. If you have tomorrow tympanoplasty or ear surgery, yesterday you should have the roadmap regarding your surgery, how you will proceed, how you will keep incision, when you will give infiltration, the 10 minutes before paint and drape. So these are certain rules and regulation, or you can say roadmap, which you have to follow it throughout your life. So important instruments are microscope, drill, irrigation, suction and hemostasis. Again, all these things we will discuss during dissection. Now, decision making in ear surgeries. When we have to operate and when we have to give medical management. Shortly, I write all these things. If patient is symptomatic, then you have to treat it. If you suddenly find any findings without any symptoms, please don't treat it as far as possible. If there is a perforation, you see round window, you explain patient, because of this round window, patient does not have any complaint at that time when you see the perforation. But you have to explain them that your round window is exposed and it is possible that because of CSOM, because of chronicity of disease, you will have conductive as well as sensory neural deafness as this disease progress. So symptomatic and disease progress, these two things are important to decide the surgical management. So if patient is coming with us with deafness, vertigo, or dizziness, imbalance, tinnitus, or sometimes some extra or intracranial complications. Then we have to decide regarding the surgical management. Myringoplasty, yes, perforation with hearing loss. If there is a marginal perforation, we have to see about the cholesteatoma. Ossiculoplasty. Ossiculoplasty may be because of ossicular erosion, fixation or dislocation. It may present with or without perforations. And in some of the surgery, some of the cholesteatoma surgery, as we are doing cholesteatoma surgery, first debridement of the disease, and then if required, after 6 months or 1 year, we are doing the second surgery for the hearing. So, ossiculoplasty for that. Now, these are the site. This is head of Malleus. Here you can see in atic region, superior wall as well as lateral wall, you can see neo-osteogenesis, which make the ossicles fixed. Same way, body as well as short process of incus, fixity. If there is otosclerosis, tympanosclerosis, anything, these type of conditions, it leads to the fixation of stapes. Again, lenticular process, incus is 81% is affected in CSOM. So, first and foremost ossicle which affect during any disease process is incus. Next, these are the fixation, disarticulation, dislocation and erosion. Again we will discuss it in the cadaver. Now, these are different type, site, size of the perforation, how we have to manage it. Again we will discuss in cadaver as we will operate for the ossiculoplasty even in on the 12th during surgery, where we have to keep incision in primary surgery, in secondary surgery. So, this is the incision from 12 to 5 o'clock, and we have to keep more distance, you can see here, posteriorly. When we have to remove the tympanosclerotic patch, and what we have to take precautions. Only one thing, if we are removing the tympanosclerotic patch, one thing is most important, don't remove, don't injure anterior annulus. That is most important, anterior annulus. Because in case of inlay technique, we are tucking our graft medial to anterior annulus. Next is stapes surgery. When you have to do, there are specific indications. Fixed stapes foot plate with good inner ear reserve. If there is an inner ear involvement, we have to explain the patient. You have mixed hearing loss, so we cannot give 100% result to you. Or hearing aid is also useful in this case. If you are not expert, please take help of expert. And along with that, we have to rule out other conditions, differential diagnosis of otosclerosis, SOM, tympanosclerosis, persistent stapedial artery, disarticulation of the incus, fixed malleus. If patient has a only hearing ear means other ear is dead ear. So, one should not do surgery for improvement of hearing. One thing, cholesteatoma, it is better to do by experienced surgeon. We have to take advice previous to the surgery. If only hearing ear and serious otitis media, if it is not relieved by medical treatment, we can put the myringotomy tube. Cholesteatoma in only hearing ear, our motive is debridement of disease and giving patient to safe and dry ear. Here hearing ear is not our motive. No ossiculoplasty if cholesteatoma, CSOM, facial nerve paralysis or temporal bone fracture. If hearing is only object, then one should not perform ossiculoplasty. Clear? No. Again, so if patient has a cholesteatoma, CSOM, facial nerve paralysis, temporal bone fracture, ossiculoplasty, we have to keep it for the second stage. One thing, you should not perform on the same stage. Staging is required. If you want to do stapes surgery, most important thing is aseptic precautions. No inflammation of external ear or middle ear or perforation. Canal stenosis, more improvement we can see in the post-operative patient rather than post-inflammatory patients. That means if we have canal stenosis due to inflammation and we have canal stenosis due to post-operative procedure, we can have good result in post-operative procedure rather than post-inflammatory. Again, stenosis can occur in post-inflammatory conditions. Now, these are dissection: canalplasty, cortical, posterior. That we will again discuss in our cadaver. Most important thing, problem and solution in mastoid surgery. One, how you will control the bleeding. How, if you see fistula, how you will operate in CSOM. How you will deal with the facial nerve paralysis. If there is injury to sigmoid sinus and dura. So for that again we will all discuss in the cadaveric dissection. CT scan. બધા આવી ગયા? Or 22. Okay, Abha madam will come at 10:30 or 11. Bon wala. We will do it fast. CT scan just what is important. We will not discuss axial and coronal in detail. We will see first sagittal. We see all the three, but more important at present during this section is sagittal section. How many of you have a experience of CT scan reading all the time, daily? How many of you? One should have, yes, one should have habit of reading CT scan and on CD. In each and every cut you can see how these variations we can see in disease progress, which structure is involved, all this, because in plate they are not giving all the cuts. क्या हुआ? Okay, axial. Just for the sake of first visualization of CT scan, don't worry if you don't remember anything, please. In case of axial cut, we have to move superior to inferior. In case of coronal, we have to move anterior to posterior. In case of sagittal cut, we have to say either medial to lateral or lateral to medial. Clear? So this is axial cut of this cadaveric bone. Now what we should see in any temporal bone? So most important thing is morphology of tympanic bone. If you clinically see any aplasia or atresia of external ear, then you will see deformity of tympanic bone in the CT scan. So first requirement is our detailed examination with headlight as well as otoscope. That is most important and reliable examination. And 85% of the disease is diagnosed based on our otoscopic and detailed examination. Clear? If we require, in some of the patients we have to do CNS examination. If any problem, please tell me. I will repeat it again 3, 4, 5, whatever time you will say. Okay? મોટું કરવાનું है यस ये वो वाला है उसमें होगा वो वाले उसमें होगा ना एनलार्ज नहीं हो रहा है इसमें एक काम करो बीजू बीजू लैपटॉप बदली काढ़ो यस शी इज़ राइट वी हैव टू मेक इट लार्ज जस्ट वेट गिव मी 2 minutes नो 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 जस्ट चेंज either change laptop or open internet because yes it is not clearly. So in external auditory canal we have cartilaginous as well as bony portions. On the medial most part of the external auditory canal we have notch of Revenus, and in lower part of the tympanic bone we have bony tympanic annulus, one bony tympanic annulus, anterior and posterior tympanic spine where tympanic membrane tympanomalleolar fold is attached from the neck or neck of the malleus to the anterior and posterior tympanic spine, and tympanic membrane is fixed in this fibrous annulus is fixed in this bony annulus. So this is lateral wall, but still lateral wall is not complete. Lateral wall is formed by pars tensa, pars flaccida and part of lateral attic wall. Lateral attic wall means part formed by the scutum bone, and projecting bone is known as scutum. Clear? Now middle ear cavity, it has malleus, incus, stapes, tensor tympani, stapedius, these are the contents, chorda tympani and facial nerve, and tympanic plexus, these are the neural structures within the middle ear cavity. Lateral semicircular canal that we can see in the posterior epitympanum. Posterior epitympanum. Now middle ear cavity is divided into hypotympanum, mesotympanum and epitympanum. In epitympanum, which structures are present? Head of malleus, body of incus, that is content. But if we see the boundaries of epitympanum, there is a lateral wall, that is lateral attic wall, medial wall, that is formed by the medial wall formed by the petrous bone, anterior wall, zygomatic process. Posteriorly, it continues with the antrum through the editus. Clear? I am clear? And roof is tegment. So, boundary is attic wall, petrous bone, tegment wall, zygomatic bone. Here there is continuous with the antrum through the editus. Content is head of malleus, body of incus. Now, which structures divide epi and mesotympanum? That is the horizontal facial nerve. So, inferior to horizontal facial nerve lies the mesotympanic area. In mesotympanic area, we have handle of malleus with umbo, one thing, long process with lenticular process, two, stapes, oval window. So, these are the part of ossicles on the promontory, which is bulge of basal turn of cochlea, promontory. It is tympanic plexus, that is neural structures. Okay. Inferior to promontory, there is hypotympanic air cells. Again, it is in the mesotympanum. Anteriorly, anterior to promontory lies the ET tube. Anterior to promontory lies the eustachian tube, along with tensor tympani muscle superiorly. Clear? And medial to eustachian tube lies internal carotid artery. Posterior to the promontory lies the oval window, round window, we have already seen part of malleus incus and stapes. The stapes is connected to the posterior bony meatal wall through the stapedius to the pyramid. Clear? So stapedius is connecting muscle from pyramid to the head and neck of stapes. Clear? And again, this middle ear cavity is divided into epi, meso, hypo, protympanum and retrotympanum. If you want to talk about retrotympanum, what are the important structures? Sinus tympani, facial recess, posterior tympanic sinus, subtympanic sinus and part of the hypotympanum, inferiorly air cells. So that differentiate from the meso to hypotympanum, funiculus line. Again, it will be seen on the bone cadaveric with microscope, and one lecture is endoscopic anatomy of the middle ear. Again we will repeat it on that day. So middle ear cavity content neural, again jugular bulb and internal carotid artery. If you see the middle ear cavity, anteromedially will be internal carotid artery. Anteromedially, not towards the lateral wall. Anteromedially is internal carotid and posteromedially is jugular bulb. So in hypotympanum, anteromedially lies the internal carotid artery, posteromedially lies the jugular bulb, and that's why in case of glomus jugulari, we are seeing the bone junction between the jugular bulb and carotid canal. That crest is eroded in the jugular glomus jugulari. Clear? So these are the middle. Now editus and antrum. If you see antrum, lateral to antrum lies the entire squamous bone, which is known as mastoid bone, and medial to this antrum lies the petrous bone, because medial wall of the middle ear cleft is formed by the petrous bone. Clear? And we can see the bulge of the lateral semicircular canal in the floor of mastoid antrum. So in case of CT scan, what we should see? First, pneumatization of mastoid, 1. Second, tympanic bone, that is bony external auditory canal. 3, oval window and round window. 4th, ossicular chain, whether it is normal size shape, any disarticulation or fixity or fixation, and facial now, dehiscence, sinus and dura plate. So if you see here, we can see from medial to lateral we have to see. This is canal. This canal is external auditory canal. Anteriorly, anterior to middle ear cavity and external auditory canal is TM joint, and posteriorly lies the mastoid. So at this level, here we can see entire mastoid. When we can see tympanic bone, or we can see external auditory canal, posterior to it lies the mastoid process. This process, it shows what we have to drill. So from here to here you can see pneumatization. But one more structure, this structure is sigmoid sinus. You can see there is some deepening into the mastoid process. This sigmoid sinus can come up to here. Okay. So this is external auditory canal. This one is internal carotid artery, and this is jugular bulb. So this is hypotympanum. Now main thing, middle ear cavity. If we see middle ear cavity, from epitympanum, this is epitympanic area where we can see head of malleus and body of incus. So this is epitympanic area, and this is facial now. This one is facial now. Clear? So this part is epitympanum, this part is superior part of the mastoid antrum. I will not go in detail. Today is not radiological aspect. Next, in middle ear cavity, here we can see these two dots, that is handle and long process of handle of malleus and long process of incus. Here you can see posterior semicircular canal and cochlea. Again, basal turn of cochlea that we have to see in otoscopic examination as a promontory, along with round window and oval window. So, sagittal section. Yes. Now, why sagittal section is important? Whatever we are dissecting, that same way we have to proceed from lateral to medial. So, here you can see this is TM joint, this is entire external auditory canal. You can see this is entire round oval shaped bony part is tympanic bone, and this entire thing is mastoid process. So, this from here to here, this is tegmental wall, tegment tuberi, tegment tympani and tegment antri. Clear? This is sigmoid sinus wall. Now I go medially. As I go medially, here you can see anterior and posterior tympanic spine. This is epitympanum. Some ossicles is seen. At present, don't try to mug up that this is malleus or incus. Just see it, observe it. This is tegmental wall. This is sinodural junction. Even this is sinodural junction, where tegmental wall and sigmoid sinus is. So this is sinodural junction, from where we have to remove disease properly. So as we go medially, see, this is the notch of revenous where superiorly bone is dehiscent, and this is epitympanum. This part is lateral semicircular canal. So up to here our all procedure is known, whether it is cortical, whether it is canal wall up, canal wall down. We have to dissect up to here. Clear? After that, if our cholesteatoma, if it goes supra or infralabyrinthine, or towards the cochlear, or towards the petrous apex, or towards the posterior pyramid, this pyramid is divided into anterior pyramid and posterior pyramid. So if disease progress towards the posterior pyramid, we have to go in that way. If it goes towards the anterior pyramid, so we have to proceed from the canal. Here from the mastoid process. So by that way we will discuss it on the temporal bone. So now dissection. In dissection, first step is canalplasty. First is identification of surface landmark. Second, canalplasty. Third, cortical mastoidectomy. Fourth, posterior epitympanotomy. Posterior epitympanotomy means exposure of epitympanum from the mastoid side. That is posterior epitympanotomy. Then identification of vertical facial nerve with chorda tympani. Then posterior tympanotomy. Then which structures we have to define it? Incudal buttress, anterior and posterior buttress, facial bridge, facial ridge. How canal wall down we can convert it into the canal wall up into canal wall down with removal of facial bridge, ridge, lowering down of facial ridge, removal of facial bridge, exposure with adequate exposure with removal of anterior and posterior buttress, and socialization of cavity. You have to form cavity in such a way that we don't have to move the patient's head repeatedly, or we don't have to move our microscope to see medial structures. So wide exposure laterally leads to very good visualization and dissection on the medial side. And last one is good meatoplasty. So whenever we see the temporal bone and we want to start the cortical mastoidectomy or tympanoplasty or any procedure, first we have to identify temporal line on the temporal bone. One, superior temporal line is important structures which gives identification of floor of middle cranial fossa. So we don't have to dissect superior to this superior temporal line, one thing. Second thing is posterior bony meatal wall. This posterior bony meatal wall with spine of Henle, we have to preserve this posterior bony meatal wall along with thinning of it. So we can identify our vertical segment of facial nerve. And third thing, we have to just draw the line from superior temporal line towards the mastoid tip, towards the posterior bony meatal wall. That tangential line give the probable site of sigmoid sinus. ચાલશે. So today we have not described CT scan completely, just we have seen pneumatization. Our bone has good pneumatization, one thing. Tegmental wall we have seen, sigmoid wall we have seen, posterior bony meatal wall is properly seen, even ossicular chain are clearly seen. So that we have to see before surgery, sagittal section. But if we want to see all the structures, then we have to correlate axial, coronal and sagittal, all the three cuts before surgery. So I am at present I will operate right side of the cadaveric bone. If picture is not clear, please tell me. Picture is clearly seen on the screen. Fine focus is required. Yes? Okay. So here what you can see, what structures you can see at present? Now clear? Clear? So whenever we are, I'm audible? Whenever we are starting our surgery, first thing is incision, then second is mucoperiosteal elevation. Whenever we are doing mucoperiosteal elevation, in case of middle ear surgery, that is tympanoplasty or ear surgery, our exposure should be up to here, from 12 o'clock to here. That skin and mucoperiosteal layer we have to elevate anteriorly up to 12 to 6 o'clock. Wide exposure is required to see superior wall of external auditory canal. Remember, superior, this is superior wall of external auditory canal. See, This is superior wall, this is posterior wall, this is inferior wall, and this is anterior wall. Okay. So first thing we will see tympanic membrane. It is visible there, tympanic membrane. So it is not, it is perforated in this bone. What you can see here, again, remember this is superior wall and you have to see in all procedure. Why? That I will explain during this section, but it is must. This one is posterior wall, inferior wall and anterior wall. Medial part of this external auditory canal, here you can see the tympanic membrane with some of the big perforation, and from that we can see the handle of malleus. It is possible to see there? Fine focus is required, yes. Clear? Okay. When we are doing tympanoplasty, whenever we are doing tympanoplasty, most important thing is visualization of annulus, posterior annulus, inferior annulus and anterior annulus. So, this is posterior annulus here. In this bone, it is not properly preserved. This is perforation, that's why here there is a posterior annulus, but you can visualize anterior annulus. This is anterior annulus. See. Seen there?
Yes, ma'am.
I will magnify. Clear? Okay?
Yes.
So, this is anterior
So, little
annulus.
fine focus is required.
Fine focus.
Yes.
Center. So, only for the annulus I am focusing this much. So, we have to see, we can see whether we can annulus, we can see annulus, annulus anteriorly, inferiorly and posteriorly. If we cannot visualize it, we have to perform canalplasty. Canalplasty means widening of the bony external auditory canal. Now, posteriorly we can wide very easily, but whenever we have to wide anteriorly, most narrowest part, is this, where there is a, here tympanic membrane kadi nakho, because it is not visualized properly. Perforate. Mane forceps આપો છો ને. I cannot perform myringotomy and grommet in this bone. Forceps are આપજો. Whatever I am facing, everyone during surgery, it happens in surgery as well as in dissection. So don't you worry for anything. So here there is a good space between the neck of malleus and anterior wall. But if there is a no space or there is anterior canal wall stenosis, we cannot stenosis but overhang. लो आप पकड़ो. In that case, we have to do canal wall plasty in anterior wall. Here we can see both the annulus. This and it. So canal wall is adequately wide. But whenever annulus is not seen, we have to perform canal plasty. How we can perform? Nani badlaisu. So first step, okay, Chaitri, we have to work with two hands under microscopic vision, simultaneous. Once you have to do dissection with drill, after that you will do not that way. Simultaneously we have to do both the things, and that habit we have to try here in our cadaveric bone. So Chaitri will explain all the rules and tips of. So this is canal plasty. See movement of my burr. Picture is clear?
Yes, ma'am.
So for demonstration purpose, we will do canal plasty properly, so we can visualize all the structures clearly. What you should take in consideration that we have to, whenever we are performing canal plasty, posterior inferior aspect of the annulus, there is lies the facial nerve. So in that case, we have to take more precautions on the inferior aspect. So movement of burr is most important, always from medial to lateral, not from the lateral to medial. Otherwise we end up into the injuring the medial wall of the middle ear. Yes, Chaitri.
Ma'am, should canalplasty be performed in all the patients or in some specific?
So canalplasty is indicated one thing. Posterior canalplasty is to visualize the annulus as well as ossicles. Anterior canalplasty to visualize the anterior annulus. Here there is a very good space between the lateral process of the malleus and anterior wall. So it doesn't require here. Okay. And in case of the cholesteatoma, in case this superior wall, that we have to dissect to see the entire atic wall properly. So movement is very much essential, that it should go like you are painting something, painting. You don't have to just give pressure on the bone, never. And never use which type of burr? You have to always use sharp burr.
Appropriate.
Otherwise you always give pressure on the bone and it will end up into injuring the vital structures. Now I will show you ossicular chain, handle of malleus. આ દેવા દો અહીંયા નોઝ પેલી માઇક્રો આપો. So whenever we are having microscope is required with good magnification, one thing, because we have to work in very small region along with millimeter. So good microscope with good magnification. If you want to see any structure in detail, you have to adjust into higher magnification. Suction and this micromotor drill and handpiece, we have to use as a pen always. Keep pressure and keep your hand over the patients. So it will not, your hand should be not in air. So in anywhere it goes and it can damage the structures. આ બાજુ રાખો એટલે કદાચ આ લોકોને પૂછવું હોય તો ખબર પડે. So here you can see in the medial wall entire that annulus is very much visible after removal of this much of bone. So this is adequate size of canal, so it doesn't require canalplasty. But if we want to do canalplasty, this is the way we have to perform the canalplasty. Now second stage is cortical mastoidectomy. For cortical mastoidectomy, we have to identify our external landmark. Picture is clear?
Yes, ma'am.
In external landmark, you can see spine of Henle here. This is spinal of Henle. This one is zygomatic process. Seen there? Zygomatic process, superior wall of the external auditory canal, and this temporal
Superior
line
temporal
goes
line.
like this. Clear? It is clear there?
Yes, ma'am.
So this is the superior border. This is external auditory canal. That is anterior border. And tangential line is sinus
Posterior.
line. But it is probable line. So first our dissection will start from the 12 o'clock. 12 o'clock. First we will make line. This is superior
Temporal line.
temporal line, one thing. Second is posterior bony meatal wall. Clear?
Yes, ma'am.
And third is joining these two. So our target is superior temporal line 1, posterior bony meatal wall 2, and line joining these two. Clear?
Yes, ma'am.
So these are our external landmark, and spine of Henle is important structure which is lateral, extreme lateral of our mastoid bone, and deeply it suggests the level of adductus. Now whenever I am using burr according to size, if we are starting our cortical mastoidectomy, we should start with 6 number, 7 number or 5 number according to the age and size of mastoid. 1. If we are doing dissection in the medial side, that is in the deeper aspect of the mastoid, then we have to shift to either 2 number or 1 number according to the size of that region. પાછળ જેટલા બેઠા છે પ્લીઝ આગળ આવી જાઓ, જોઈ લો ને પાછળ.
Yes.
So that is the size of burr. Now cutting edge, we have to always cut with the side of the burr, not with the tip. So whenever I am, so see, so this is side of burr, and we have to remove bone from anterior to posterior, from superior to inferior. Anterior to posterior on the superior temporal line, superior to inferior over the posterior bony meatal wall, again superior to inferior over the third boundary, posterior boundary, and we have to remove the bone equally. We don't have to make one small hole opening
Yes, ma'am.
into the mastoid antrum.
What is the triangle of attack, ma'am?
Triangle of Mequan's triangle. Mequan's triangle is the triangle which lies postero-superior to the spine of Henle, postero-superior to the spine of Henle. So this is spine of Henle, and this is postero-superior region. This is the area is known as Mequan's triangle, and probable site of mastoid antrum. It lies 2.5 centimeter medial to this external surface. Clear? In case of pediatric patient, antrum will lies if you dissect 1 to 1.5 centimeter, and in case of adult it's around 2 to 2.5 centimeter. Picture is clear?
Yes.
Yes, ma'am.
You don't have to not only structures but how we are doing dissection. That is most important thing.
As
Position of surgeon is also important.
So as you can see, we are drilling with the lateral part of the burr, side of the burr, and we are doing the long strokes along our first marking which we decided, and we are doing long strokes along that.
Picture is clear? So here you can see this is sclerotic bone, but one air cell is coming in the view. Clear?
Yes,
You
ma'am.
can see here.
Yes, ma'am.
Dissection is always with the side of the burr, not with the tip. Yes, picture is okay. Here you can see two air cells, big air cells. One is here, one is here. Clear? And in our CT scan, this lateral part of the mastoid antrum is pneumatized. पकड़ से बेटा. If you see, if I am see the suction of the fluid even from the middle ear. From medial to lateral, from medial to lateral. Any question? We have already given that surgical modules, and all these surgical and technical aspect is written in that module. So I think you have go through it. Don't rush to see the mastoid antrum only. We have to see tegmental wall, sigmoid wall, thin, comparatively thin posterior bony meatal wall, and in the floor we will directly see the lateral semicircular canal as antrum will come. So this is posterior boundary. Saline properly absorb. Now you can see the air cells in the lateral aspect of the antrum. So it is pneumatized mastoid. पुस्तक क्या नंबर नहीं बढ़ रहा आपके यहाँ 7 છે ને પછી 6 તૈયાર રાખજો. Picture is clear?
Yes.
Any question? Yes, corner septum. Yes. Yes. Okay. At present you can see external auditory canal with this drill part of the mastoid cortex, not mastoid antrum. When development occurs, this petrous bone and squamous bone, they are developing and there is a connection or articulation between the petrosquamous suture in the medial wall, of the this squamous part. So it is just lateral to the antrum. So many a time we feel that our mastoid antrum is quite superior, but it lies medial to this corner septum. And if you dissect temporal bone, pediatric temporal bone, chances of corner septum is seen more in 2 to 3 years of age, because in our cochlear implant patients, we almost see in each and every patient corner septum is there. So we will show a CT scan also, how it looks. Along with removal of this bone, we have to make the posterior bony meatal wall thin, but never perforate it, never remove it. Otherwise, post-operatively, chances of skin flap over the broken posterior bony meatal wall leads to acquired cholesteatoma. Picture is clear, no? So we have to go slowly from medial to lateral. Sister, bar बहुत सारी नहीं. You can see all aerated cells lateral to the mastoid antrum, and mastoid antrum is big pneumatized cell of the mastoid. It is always present even in highly sclerotic temporal bone. Sister, बीजी बार आपसो.
Excuse me, ma'am. Now, any specific thing to be kept in mind while drilling in and around the cells, like you are in the.
Whenever we are dissecting lateral to mastoid antrum, we have to take care in which area. One specific, one at the dural plate, second at the sigmoid plate, third at the posterior bony meatal wall. Whenever we are dissecting it, when we close to this dura or sinus, change of this burr noise, sound, one thing, and second thing, you can visualize the vessels before these structures come. So before dural plate eroded, we can see the vessels over the dura, one thing, and second thing, color. In dura there is a pink, over the sigmoid sinus it is blue in color. થોડુંક આગળ લઉં છું. Picture is clear? Okay. So still you can see pneumatized bone, but we don't have to worry in this region. We have to worry in this region. Take precaution. Here and here in posterior bony meatal wall. Here we can see the anterior part of the posterior bony meatal wall. This is posterior bony meatal wall. So we can visualize the entire thickness of posterior bony meatal wall.
Ma'am, can you
Clear?
centralize a little bit?
Yes.
Yes.
If picture is not clear, please tell me. Now you can see big pneumatized cell. This is spine of Henle, posterior superior to it. That is the exit site of the mastoidectomy. Clear? You can see I am doing thinning of posterior bony meatal wall along with removal of this pneumatized cell. Picture is clear?
Yes.
So this is sinus plate, dural plate, sinus plate, posterior bony meatal wall, and this is external auditory canal. Okay, your picture should be like this if you want to do cortical mastoidectomy. Picture is clear? Yes?
Yes.
And don't just rush to dissect more and more. We have to remove our bone dust with proper irrigation. Now irrigation is very important part of our dissection, because not only it cooling the bone, but it also moist the bone, one thing. Second thing, it remove the dust. Third, what is important thing? Third, we can see structures through this saline medial to this bone. If clear, picture is clear? This bone dust create neo-osteogenesis post-operatively. So we have to remove it properly. If we have deep mastoid tip, well
Centralize.
pneumatized.
Ma'am, if you can magnify a little less, then yes.
Yes, picture is clear. So here you can see you have atic cholesteatoma or posterior superior cholesteatoma, well pneumatized temporal bone, well pneumatized mastoid. If our disease is extending, cholesteatoma is extending up to the mastoid tip, we have to clear it, we have to debride it. Here you can see level of external auditory canal, inferior wall, and this is tip. So this is deeper than external auditory canal, and when we perform the canal wall down, mastoid cavity is deeper than the external auditory canal, and it leads to more cavity care, draining cavity, and for that we require the obliteration of the big mastoid cavity. We don't have to move all the time either bone or our microscope to see the structure medial to our dissection, and for that we required the socialization, that is beveled of this edge. So this is cortical mastoidectomy, where we are reaching up to the lateral semicircular canal. Any question? Now I will shift to the smaller burr for the mastoid antrum to see the lateral semicircular canal, lateral semicircular canal, as well as short process of incus. So see my size of burr. It should not touch even inferior to, and I have to drill like this, from medial to lateral, from medial to lateral. Clear? So what is the inner landmark for the cortical mastoidectomy? Anyone? Inner landmark for the cortical mastoidectomy is sinodural angle posteriorly. Anteriorly, well seen mastoid antrum with lateral semicircular canal in the floor and mastoid tip. So we have done it. This is mastoid tip, sinodural angle and mastoid antrum, but we have to see the lateral semicircular canal. For that, just I am removing some bone lateral to it. And you can differentiate bone of lateral semicircular canal with well pneumatized bone.
Yes.
These are some pneumatized cell that I am removing to widen the cortical mastoidectomy. Then I will show you every structure in magnification. નાની બરાબર છો નહીં, small. For editus size is around 4 millimeter in adult, and we have to use our smaller burr. So our burr should not injure tegmental plate 1, ossicle 2, and third thing is second genu of facial. Now I will show everything on this bone. Please wait for us some time. After this dissecting this mastoid antrum, I will show you where is tegment, where is second genu of facial now. So here you can see This one is sinodural. This is sinodural angle. This is dural plate, this is sinus plate. This one is posterior bony meatal wall, and here you can see this is lateral semicircular canal. This lateral semicircular canal, see little bit pneumatized cell over it, but color of lateral semicircular canal and other pneumatized cell is different. It is dense and white. Whenever I am doing dissection lateral to mastoid antrum, it is with big burr, big size burr, that is around 6 or 7. But if I want to do dissection here, I have to take smaller size of burr. So now you can see lateral semicircular canal, dense white bone. Clear?
Yes, ma'am.
Appreciate or not? Everyone? Clear? So this is cortical mastoidectomy. Clear? Now we have to perform posterior epitympanotomy. How this is cortical mastoidectomy? We can see here one thing is external auditory canal with handle of malleus. This is dural plate, this one is sinus plate, this is thin, comparatively thin posterior bony meatal wall, and in the floor of mastoid antrum there is a lateral semicircular canal. Okay. So if we perform this way, then this is complete cortical mastoidectomy. Now second is posterior epitympanotomy. Before that, why we should take smaller burr at the level of posterior epitympanum? Why? I will show you in the microscope. Yes. So this is tegmental wall. This one, this area is area of second genu. This, and this is lateral wall of the attic. If bone size is bigger than this region, then we can injure superiorly tegment, inferiorly second genu, and medially lateral semicircular canal, laterally lateral attic wall. So we should take adequate size of burr. Now for posterior epitympanotomy, you have to see structure with saline also, because short process of incus first visualize in the saline. I did high magnification, so you can see short process of incus, LSC and other structures very well.
Ma'am, while drilling in this area, any specific landmarks we need to focus on while drilling, any particular position?
For posterior epitympanotomy. For posterior epitympanotomy.
Yes.
Posterior epitympanotomy means exposure of posterior epitympanum.
Right.
And it is through the mastoid.
Right.
When we are going through the mastoid, first structure encounter us is short process of incus. Right. If our burr is touching to short process of incus, it will lead to immediate sensory neural loss because of stapes. So if you want to do any surgery, or if there is a cholesteatoma patient, you can disarticulate the IS joint before this. So chances of sensory neural deafness will be less. And second thing, in majority case of cholesteatoma, incus is first structures which affect, and that's why you have to remove eroded entire incus. So it is best to dislocate this.
And then do the drilling.
Yes. In case of cholesteatoma. And our movement always from medial to lateral, medial to lateral.
Ma'am, can you centralize a bit?
Okay. I am focusing only on epitympanum, not on the mastoid tip at present.
Ma'am, while drilling, if this area is full of granulations, how will we proceed? How will we identify this?
Yes, if there is a full of granulation or full of cholesteatoma. So first, whenever there is a CSOM with granulation or cholesteatoma, you will see middle ear exploration first. Then you will start cortical mastoidectomy. First thing. If you see that cholesteatoma is extending to antrum, mostly it is extending to editus antrum as well as stapes area. First you have to see ossicular status through the middle ear. If incus is eroded, we have to remove it. We have to identify, we have to remove it. So chances of this ossicular chain injury will be not there if we do the posterior epitympanotomy. But in case of cholesteatoma or CSOM, anything, first we have to see middle ear, because with elevation of tympanomeatal flap, we see the medial wall, so we see the ossicles, we see the scutum, and then we proceed to the cortical mastoidectomy and another procedure. Just I focused only on posterior epitympanum, so you can see that structures properly. Sanika, little bit moti, jarak moti. Good morning, good morning. Please come, madam, आप आगे आ जाइए, please. हाँ. Tegment tympani. Whenever we are okay. Tegment over the editus, tegment over the mastoid antrum, and tegment over the epitympanum. Whenever we see the tegment, this tegment, it goes from posterior to anteriorly. So the distance between the mastoid antrum and tegment will be more. In editus, it is comparatively less, and because it is sloping down towards the anterior epitympanum. Our floor of middle cranial fossa, as it goes from mastoid antrum towards the eustachian tube, it goes sloping down. So distance in epitympanum is less, distance in mastoid antrum is more, because this tegment is sloping down towards the anti-epitympanum, and that's why whenever we are dissecting in the epitympanum, posterior or anti-epitympanum, we have to switch over to the 1.5 or 1 millimeter of burr to protect not only tegment, lateral wall, inferiorly facial and medially lateral semicircular canal. मैडम आप आगे आ जाइए ना प्लीज. मैडम ने आगे बुलाइए.
हाँ प्लीज मैम.
Now you can see lateral semicircular canal, dense bone, but it is covered with pneumatized cell. You can identify it properly?
Yes.
Okay. अनिकेता मोठी बरा.
Hello. Do you find cog? Do you find cog?
Yes, yes, we will
It's
see
a
cog. We will
permanent
see
structure.
cog. Yes.
So,
We will see everything cog, cochleaformis process. Many a time if our cadaver is fresh, then we can see the fold, but this cadaver is quite old. I don't know whether we are able to see or not. Even we can see epitympanic fold. I am doing dissection of lateral side. My burr is not in the editors. And also preservation of superior bony meatal wall. You have to see in saline, first impression of short process of incus will visualize in this saline only. See, saline आवाज saline.
Yes.
So first appearance of any structures will be seen in saline, then it will come. It is visualized there
Yes.
because I can see here. See, that is short process of incus. So in posterior epitympanotomy, first structure is short process of incus, we can see. Bone જૂનું છે ને. Bone is little bit old. If it is fresh bone, it is very well pneumatized bone. So everything we can see very fast and easy dissection will be there. But now you can see one structure is coming into posterior epitympanum.
Yes.
You can see So that is short process of incus. I will show you on with pic. This one is short process of incus. This structure.
Yes.
Clear? Now we will see body of incus. You can see body with short process of
Incus. Yes, ma'am.
Yes. Now, Abha madam, you want to ask me regarding the tegment. Here we can see tegment of editus. This structure is tegment of editus. See, this structure is antrum here. Antrum lies here. Oh. Picture is clear first?
Yes, ma'am.
Okay. So, our tegment will be like this. It going like this. The tegment above the middle ear cavity is tegment tympani. Tegment above the antrum is tegment antri. And this is editus. This part is editus. So, this tegment is tegment of editus. Now, after that we go towards the posti-epitympanum and anti-epitympanum. Cog will be seen at the junction of anterior and posterior epitympanum.
So precaution we should take that we should drill remain towards the superior canal wall, just to spare the tegment.
Yes, we have to take
Remain close.
that number of burr which if I will use here, it will not touch to the inferior wall, it will not touch to the superior wall, or it will not touch to the medial wall.
Right.
We have to take
Yes.
such size of burr.
So
for
size
the-
of burr is very
yes,
important.
very important.
Yes.
મોટી બર આપે એટલે બહાર ન કરી દો અહીંયા છે whenever I have to dissect laterally I will use bigger size of burr. Whenever I am doing this dissection in antrum, editus or anywhere, I have to compare anterior and posterior wall of dissecting region. So I can see the thickness of it. हाँ, मैं करूँगी उसके बाद देखे बिना कुछ नहीं. Clear? Clear? Some fold is seen at present. I will show you whether it is possible to see there or not. That I don't know. Find focus. मेरे को बोलना. So you can see one fold over the malleus.
Yes.
Yes. बहुत ही thin होगा मैडम. It is really difficult to visualize. In living individuals, in living patients, this fold is having vascularity in it. So it looks pinkish, whitish pinkish. But here this bone is quite old, but this structure, this structure is fold over the malleus. Picture is clear?
Yes.
So here we can see at present body and short process of incus. I am trying to visualize the malleus also. So how it looks when we see through the lateral aspect of epitympanum, how it looks. Now you can see both the structure,
Yes.
malleus as well as
Yes.
incus. Now it is clear?
Center.
Center, okay. So same picture you can see in the CT scan when you see epitympanic region. Head of malleus looks round, short process of incus with body is looking like this. So ice cream cone appearance is present because of this structure. Here this one is head of malleus, this is entire body and this is short process of incus. Clear? So this procedure is posterior epitympanum, means we are exposing the posterior epitympanum. Now here you can see our cortical mastoidectomy. Posterior bony meatal wall is adequately as well as symmetrically thin. Then, yes. How we can define that it is adequately? There are first thing one should know the anatomy of facial nerve. Facial nerve, it goes facial nerve from horizontal to vertical transfer of this facial nerve, it goes antero-inferior to lateral semicircular canal. Now I am showing you the antero-inferior aspect of the lateral semicircular canal. Yes. So this is entire lateral semicircular canal. This clear? This is anterior aspect. This one is anterior aspect. And if we dissect this inguinal buttress, this is inguinal buttress. Underneath this region is antero-inferior aspect of lateral semicircular canal. So from here, this facial nerve, it goes transfers into the mastoid component, and from here it will go to from here to here. So if we thin out the posterior bony meatal wall in such a way that if we keep our posterior bony meatal wall in front of us, this posterior bony meatal wall is just anterior to anterior aspect of LSC, anterior aspect of LSC, that means our posterior bony meatal wall is adequately thin, because we should visualize how this facial nerve transform from the horizontal to the vertical at the second genu at the antero-inferior part of lateral semicircular canal. I am clear? Facial nerve. Yes, our facial nerve, it enters into the internal auditory canal, then from there it comes out as a labyrinthine segment of facial nerve, then geniculate ganglion is the next through which GSPN is arise. From geniculate ganglion, that is the first genu which is situated anterior to the cog, anterior to the cog. From there to the second genu, that is horizontal, obliquely horizontal pathway of horizontal facial nerve. From there, second genu, facial nerve is antero-inferior to lateral semicircular canal. Now, if we can visualize this anterior aspect of the lateral semicircular canal, then that posterior bony meatal wall is adequately thin. If we measure in the vertical posterior bony meatal wall like this, if we see this posterior bony meatal wall, this one, if it is at the level of anterior
Centralized.
So, if I see my cortical mastoidectomy, you can see the posterior bony meatal wall, it is straight. If you draw superiorly, it will anterior to the anterior aspect of lateral semicircular canal. Now I am clear? Okay. So, this is posterior epitympanotomy. Okay. Now we have to find out the vertical segment of facial nerve. Before that, I will remove this pneumatized part of the medial wall of the mastoidectomy, not at the level of LSC. You can see this pneumatized part. Again I will do it with the big size of burr. Because on this horizontal path from mastoidectomy to mastoid tip, we have to define our vertical segment of facial nerve with chorda tympani. Picture clear છે?
Yes.
So, just I am making my posterior bony meatal wall adequately thin. You can see our anterior aspect of lateral semicircular canal. So, I make this horizontal path from the LSC to mastoid tip, LSC to mastoid tip. Picture is clear?
Yes.
Now I will switch over 3 millimeter. કઈ છે આપણી પાસે diamond burr? So first I will take 4.5 diamond burr to dissect vertical facial nerve. Picture is clear?
Yes.
So see, I will start my diamond burr just inferior to lateral semicircular canal up to the mastoid tip. From the LSC inferior aspect to the mastoid tip. Clear? Saline barabar awa de. And my movement is always parallel to vertical facial nerve. As we go medially close to the facial nerve, in living patients, we will find first blood vessels and then white thread-like structure. So it is very well visualized in the patient. Now we will see how it appears in our cadaveric bone. Yes. Yes, picture is clear. I will keep my eye on the short process of incus, lateral semicircular canal, posterior bony meatal wall and mastoid tip. I don't have to perforate the posterior bony meatal wall during this. I have to make horizontal path from mastoid tip to the lateral semicircular canal, inferior to the short process of incus. Just magnify करूँ છું. Let me see how much we can see. Yes. So our area is inferior to LSC up to the mastoid tip is possible to see with this magnification. Our nerves always see first in the saline. Some thread-like structure. Yes.
Ma'am, what care and irrigation should we take at this point of time and also in the direction of burr?
First thing, when mastoid segment of facial nerve, it go inferior from the lateral semicircular canal to mastoid tip. This traveling of facial nerve is not in a linear and straight way. If we see facial nerve at the level of LSC, it is more medial. If we see towards the mastoid, it will go laterally. And chorda tympani more lateral than the facial nerve. So as we go superior to inferior, facial nerve appear inferiorly first because it is laterally at the inferior level, and at the level of LSC it is somewhat medially. Clear? I am clear? You will even see the change in texture of bone. Now it is not pneumatized bone. બરાબર છે. Picture is clear, no?
Yes.
There are two thin fibers is visualized at the level of mastoid tip. Let's see whether it is facial or something else. But we don't have to press. We don't have to any dissection with pressure of our. It should be just smoothly as much as possible. Otherwise, you will tear at one side. And facial nerve never come entirely. You never see facial nerve के पूरी की पूरी दिख गई. No, never at all. It always come in segment. Inferiorly first, near the lateral semicircular canal. So it always appear in segment. Many a times pneumatized cells close anterior and posterior to facial nerve. It will change the pathway of the facial nerve. Some fibers is visible at the towards the mastoid tip, but we have to see entire facial nerve. After delineation of facial nerve, we will discuss the landmark to identify all segment of the facial nerve. Just a pathway, Anikata 3 millimeter. We should use 3 millimeter of diamond bar for facial nerve. पता है You can see entire facial nerve in saline also. Yes, this is the inferior half of the facial nerve. So you can see the just slight, it is visible here, this entire. Let's see what is chorda and where is facial now. Now it is visible. This is facial now, and this is coda. Clearly seen? But we have to still delineate it. Now it is very well seen, superiorly also.
Ma'am, can you centralize the picture so that we can see it in relation with the incus? Yes.
Yes, clear? So now again I have to explain each and every segment of facial now. Before that, just I want to dissect somewhat more so we can visualize it properly. You can see segment of coda. Karu, fine focus karu. You can see both now, facial as well as coda. Now you can see picture very well. Yes?
Yes, madam.
So again, low magnification. Now see. You can see here now. Pointer. Yes. This is facial now. This one is facial now. In patient, here we can see the vascularity. And whenever we open the bony canal, remember, whenever we open the bony canal, even with the diamond burr, first thing is bleeding from that side. If you see bleeding close to here, that means you have exposed the bony canal. Here at present bony canal is intact. This is facial now. It goes like this. Chorda tympani now arise anywhere 5 mm above the stylomastoid foramen. It can arise from anywhere, any side. Usually above the 5 mm above the stylomastoid foramen. So this is lateral semicircular canal, this is mastoid tip. We have to make the horizontal path with thin posterior bony meatal wall. Even my bony meatal wall is little bit perforate because of I took 4 mm size of burr. We have to take smaller size of burr. That side of burr dissect the posterior bony meatal wall also. So we have to take 3 mm size of burr. So this is the vertical facial now with branch chorda tympani. This is entire posterior bony meatal wall with superior wall, inferior wall, anterior wall. ET tube will be here. This is tegmental wall, sinodural angle, sinus, mastoid tip. So first we have done cortical mastoidectomy, second posterior epitympanotomy with identification of 2 important structures, that is short process of incus. Then we dissect little bit more to identify the superior aspect of the both head of malleus and body of incus, which is seen similar in the CT scan. You can see ice cream cone appearance, round head of malleus and body of incus. Now facial now, if we see horizontal facial now, at that time I will tell you landmarks of horizontal facial now. But here, whenever we are doing cortical mastoidectomy, never ever dissect here over the lateral semicircular canal first. So it will create fistula. It will injure the lateral semicircular canal. Second, we have to dissect inferior to LSC at the level of mastoid tip. We have to make one horizontal path. Why we have to make one horizontal path from our side? Because we are dissecting medially. So as we go in the petrous bone medially, what we will find at different level. At the level of ET tube, you will find internal carotid artery. At the level of posteromedial aspect of posterior part of middle ear cavity, jugular bulb. In the mastoid antrum, you will find the facial nerve. So petrous bone is dense and hard bone which cover very important structures. One, facial nerve. Second, internal carotid artery. Third, jugular. Fourth, very important, aortic capsule. So now I will dissect medially, I will find the structures of aortic capsule anteriorly as well as posteriorly. Clear? I am clear? Now, this is facial nerve. This facial nerve is entirely covered with posterior bony meatal wall. Clear? So we have to thin out, we have to make it anterior posterior bony meatal wall. Then and then we can see this, dissect this vertical facial nerve. If we never do the posterior bony meatal wall thin, then what will happen? We either injure the posterior semicircular canal or facial nerve, because that is not the pathway of the facial nerve. This entire facial nerve is covered with the posterior bony meatal wall. एक पूरी दीवार है फेशियल नर्व पे पोस्टीरियर बोनी मिएटल वॉल की. वी हैव टू रिमूव half posterior of it. Then and then we can open up the facial nerve. Clear? So we have posterior bony meatal wall, anterior part of posterior bony meatal, posterior part of. If we thinning out the posterior meatal wall, we will visualize this facial nerve very clearly. Now, facial nerve, it travels from horizontal antero-inferior to, this is LSC, anti aspect, antero-inferior to it, then it goes this way. So always this facial nerve, it divides the lateral semicircular canal in half. If I will see this facial nerve, see, this facial nerve, it will divide the lateral semicircular canal into half. Clear? Madam, clear? No? Yes. So this is lateral semicircular canal. If we draw the facial nerve up to here, it will divide the lateral semicircular canal into half. And that's why whenever we are starting our drilling work with diamond burr, from inferior to LSC, it is at the middle part of the LSC. From there to the mastoid tip. From there to the mastoid tip. Now I am clear? Okay. So that is the pathway of facial nerve. One. Second thing, short process of incus. It is also an important landmark for the second genu because it lies medial to. When we remove this incudal buttress, we will see second genu, medial to incus. And this cell, it is also known as sentinel cell or Herald cell. In book it is written as a Herald cell. It always present, just like mastoid antrum. Mastoid antrum is pneumatized air cell which is always present even in fully sclerotic temporal bone. Same way this cell between the facial nerve and coda, it always present and pneumatized, or sometimes it is filled with disease, but it always pneumatized and present between the facial and coda. Now what is the relation of this sentinel cell? This sentinel cell usually it is 1 millimeter anterior to vertical segment of facial nerve. Repeat again, this facial nerve and sentinel cell and chorda tympana. Sentinel cell 1 millimeter anterior to the vertical facial nerve and 1 millimeter posterior to the chorda tympani. So, sentinel lies between the chorda and facial, and this is the main pathway for the facial recess approach. Sentinel cell or the area between the chorda and facial, and this inferior to the, this is incudal buttress, where the short process of incus is rest, that bone is known as incudal buttress. Now what is incudal buttress? Why there is buttress, anterior buttress, posterior buttress, incudal buttress? Incudal buttress is a bone which derives from the tympanic bone and going towards the LSC. Why it makes one bridge? So that short process of incus stay on that one thing, and facial nerve will protect two things, because facial nerve lies medial to short process of incus, medial to the incudal buttress. I am clear? So, this area is known as facial recess area. This area is area of retrotympanum. Retrotympanum is posterior part of posterior mesotympanum, where sinus tympani, facial recess, posterior tympanic sinus, subtympanic sinus, subiculum, ponticulus, funiculus, fustis, everything is situated in this posterior retrotympanum. But if we want to reach this posterior mesotympanum or retrotympanum, we can directly go through the canal. One is directly through the canal, or second way is through the mastoid. We have to enter middle ear cavity. We have to enter the middle ear cavity either through transcanal, transmeatal. That is easy way. We can remove the scutum bone. We can approach to the epitympanum. We open the tympanomeatal in canal 12 to 6 incision. We elevate the tympanic membrane. We enter into mesotympanum. Even we can go to the hypotympanum. This is the transcanal route. If we want to go through the mastoid into the middle ear cavity, through the mastoid into the middle ear cavity, there are three approaches. One, if we enter into epitympanum, we will go through the posterior epitympanotomy. If we want to go to the mesotympanum, we will go through the facial recess area, that is posterior tympanotomy. If we want to go to the hypotympanic area, we have to go medial to vertical facial nerve, that is retrofacial hypotympanotomy. Now I am clear? So we can reach to the middle ear cavity through the canal, one directly through the canal or through the mastoid. Either posterior epitympanotomy, we will enter into the epitympanum. Through the posterior tympanotomy and facial recess area, we will enter into mesotympanum. Through the retrofacial hypotympanotomy, we will enter into the hypotympanum. Clear? Okay. So now we have already delineated vertical facial nerve, chorda tympani nerve, and we have find incudal buttress. Now what is anterior buttress and what is posterior buttress? Anterior buttress and posterior buttress. We have already removed the posterior buttress. So there is a bone. Now our medial aspect of tympanic bone, where there is a tympanic annulus, bony tympanic annulus and anterior posterior tympanic spine. This is the half curved round notch of Revinus, which is dehiscent part of bone. So it is exposed. Now we have to cover it, or we have to connect this anterior and posterior tympanic spine to tegmen. I am clear?
Okay, we have seen in CT scan, medial aspect of the tympanic bone, there is anterior and posterior tympanic spine where anterior and posterior tympanomalleolar fold is attached. That is part of pars tensa. Now, this dehiscent area, it has to reach to the tegment. For that connection, we required bone, and that bone is anterior buttress. So, bone which connect anterior tympanic spine to anterior tegment tympani, that is anterior buttress. Same way in book, different way is written anterior and posterior buttress, but buttress is connection between the tympanic bone and tegment plate. That we have to remove. Why we have to remove? Because the cholesteatoma or granulation or any disease, it lies medial to that bone, and that's why we are removing anterior buttress, we are removing posterior buttress. Now, what is facial bridge? Facial bridge is a bone, squamous bone. Now, squamous bone form the lateral part of tegment plate. Clear? From tegment plate, one overhang or one shelf-like projections towards the tympanic bone. It is known as scutum. Scutum is slight superior part of pars flaccida. With otoscope, we can see the scutum area. Clear? So, facial bridge or this scutum which covers horizontal facial nerve, that is facial bridge. The bone which covers the horizontal facial nerve is facial bridge. Now, what is facial ridge? The bony canal which is lateral to bony part, which is lateral to vertical segment of facial nerve. So, basically whenever we want to do canal wall up, canal wall down, we want to see disease in facial recess or sinus tympani, our dissection should be up to here. If in canal wall down, our facial ridge is elevated, many a times draining cavity we will see in post-operative case. Clear? Now I am clear? Anything else for the facial now? Extended facial recess approach. First I will show you facial recess, then we will see extended facial. Theoretically, when we expose the facial recess, that is between the incudal buttress superiorly, posteriorly facial nerve, posteromedially, anterolaterally. Chorda tympani, when we open this region, we will enter into the middle ear cavity. We can see, what we can see? Horizontal facial nerve, genu, stapes, crura, round window, stapedius muscle, and part of sinus tympani. We can visualize this through the posterior tympanotomy. But if we want to see inferior aspect of hypotympanic area, then we have to sacrifice this chorda tympani nerve, that is extended facial recess approach. Now, in every case of cholesteatoma, mostly if cholesteatoma is very diffuse and aggressive, this LSC projection will erode due to osteitic inflammation. Why in epitympanic cholesteatoma? We have two types of cholesteatoma, atic cholesteatoma and posterior cholesteatoma. We have two types of cholesteatoma, primary and secondary acquired. Primary acquired is posterior epitympanic or atic cholesteatoma and posterior cholesteatoma, and secondary acquired is when there is some perforation and there is a medialization of the skin into the middle ear cavity which erode due to inflammatory osteitic changes.
So basically, hello. Basically, what madam tried to sort the vertical part of facial, that is inframedial to the LSC and the chorda tympani, This is basically important when you are trying to do the facial recess approach or the posterior tympanotomy approach for cochlear implant. Or in case when there is a cholesteatoma and if you don't want to do the canal wall down procedure, it is along with keeping the canal wall intact. This is called as combined approach tympanoplasty. Okay. So vertical part of facial and the chorda identification is must or desirable in posterior tympanotomy approach not to damage these two structure. If you don't identify and directly go to the posterior tympanotomy, there are some chances of damaging the vertical part of facial.
Now facial recess approach. So for facial recess approach, okay, I highlight the only facial recess area. Here you can see sentinel cell, that is one cell between the chorda and facial, and the structures above it is incural buttress. Now we have to use 2.3 or 2 millimeter size of burr in posterior tympanotomy or facial recess approach. So see, this is my burr. Okay, and I can visualize part of the facial now as well as part of chorda tympani, even if I keep this burr here. Okay, so whether I should use or not, that we have to decide now. So this is upper part of the facial recess.
I think we can see round window, madam, directly.
Yes, everything is visualized, but we have to see every structure. Yes, because we are doing cochlear implant, that's why we always see round window first. But posterior tympanotomy, nanakdi. Posterior tympanotomy is also used for the glomus. So, in case of glomus tumor can invade into mastoidectomy, it can invade in facial recess, and it also goes medial to the facial now. So we have to open this area and we have to do both sides from canal as well as posterior tympanotomy dissection with this approach in case of glomus.
I would like to add one thing that whenever there is accidental damage or burr hole or some damage to the posterior canal wall, we can cover it with the bone pate or bone dust and put a graft and then reposition of the tympanomeatal flap to avoid iatrogenic cholesteatoma.
Yes. So, how much damage we have done, depending on them, that we have to, if lateral aspect of posterior bony meatal wall is affected, then it is okay and we can visualize, we can repair it by so many ways. Fine focus. Okay. Yes, yes. So as we go inferiorly, distance bone between the chorda and facial is become narrow. In that region we have to use smaller burr than 2 millimeter, 1 point.
And the angle between the vertical part of facial and chorda is chordofacial angle. which is usually 18 to 20, 24 degree.
It is clearly visible there.
Yes, yes.
We have to preserve chorda and facial nerve as much as possible, and that's why I am doing little bit slowly. One of our team member, Dr. Hardik Shah, we are always doing our workshop, Dr. Devang, Dr. Chaitri, me, our unit and Dr. Hardik Shah always together. But yesterday he met with one accident. By God grace, he suffered little injury and he is good now. But yesterday one big accident. So now you can see from here I can visualize round window. Now other structure I will show you. Stapedius, then stapes, oval window and horizontal facial nerve. That we have to see.
Whenever you are doing cochlear implant surgery, it's not important to just focus on the round window and then remove the knees and go into the scala tympani. It is always better to identify the stapedial tendon, pyramidal process, IS joint and the crura of stapes along with the round window, whole in one view, you know. Then you go for the round window insertion. Combined approach tympanoplasty.
For glomus, for glomus tumor,
For glomus and cholesteatoma when we are planning to do combined approach.
now here structure can be seen is, you can see this stapes. Identify? Okay. Yes. You can see IS joint. करती हूँ because yes. Now this is head of stapes, IS joint. Okay.
Madam, try to show the pyramidal process.
Everything I will show you.
Yes.
Because I have to establish the relation between the pyramid and facial nerve. So this is entire stapes and facial nerve. Now we have to see the horizontal facial nerve from here. Can you see where it is? Yes. આપણો પોઈન્ટર અહીંયા છે ને. This is horizontal facial nerve. This is stapes with oval window. Oval window is not clearly seen because we have to just focus on that oval window. Oval window and round window distance is always less than 2 millimeter. Here there is magnified, that's why it looks like this. This part is horizontal facial nerve. This is, I will show you. Now, this is horizontal facial nerve. Clear? But समझ में नहीं आ रहा है इसलिए I will remove incudal buttress. Now you can see stapes clearly. Yes or no? If you don't.
Yes, ma'am.
Okay. Okay. So this is posterior tympanotomy. Okay. If I will sacrifice this, this chorda tympani, and if I dissect inferiorly, that is extended facial recess approach. But you can see part of promontory you can see. Clear? And even round window membrane is visualized here. We have electrode. So how to insert electrode? मैं बताऊं या ये स्टेप चलेगा? How to insert cochlear implant electrode? Yes? Okay. Yes. चलावा दे तो. You can see round window membrane. Yes. So we will little mane 1 mm ni barabar. I will remove overhang over the round window membrane. Ocha. Round window membrane and oval window membrane, they are not in same plane. So it is
Yes.
visible now, round
Yes.
window. Okay. Now I will open scala tympani. पुराना कैडेवर है ना. आने दे. Because of all cadaver, મને આની કરતા 1.3 છે. કયું છે? 1.4 છે. સિસ્ટર ઇલેક્ટ્રોડ તૈયાર? So this is scala tympani.
Yes, ma'am.
Okay.
Yes.
So we are creating. First, we have to remove the overhang over the round window. We have to visualize the round window membrane. Here, this cadaver is all. That's why this membrane is not easily lifted from the bone. But we have to just remove from the anterior part. We fall down on the posterior part, and then, if we are using lateral wall electrode, we have to insert towards the floor. If we have to use the modulus hugging, it is some different technique for insertion, but I will show the lateral wall electrode. Yes. These electrodes are used for a certain time, and that's why tip is very much it is not similar in fresh new implant or new electrode. બીજું છે આપણી પાસે નવું હોય એવું અચ્છા because this is used so many times and tip is already folded છે એવું બીજું કોઈ ના હોય તો લેતા આવો then it is also not going inside because some or other reason. I don't know why. But in case of routine cochlear implant, our insertion is very much smooth. It can occur within 1 or 1.5 minutes.
Normally, do you have implant holder? So that
No, not at all because it is used so many times.
Okay.
Might have used more than 30, 40, 50 times. That's why it is kinged and lost its elasticity. That's why it's not going. Otherwise, in live patient situation, it goes very smooth.
We will show you definitely our videos. How it
Tomorrow, madam will be showing the videos of CI.
Yes.
And any precaution when it does not go to scala vestibuli?
We never have to push this electrode inside the scala tympani. It is very smooth insertion. Whenever we are doing it is very smooth insertion. If you feel some pressure when you are inserting it, you have to stop. You have to clean the scala tympani with steroid solution and then you have to again because many a times blood, bone dust or bleeding from the surrounding structures, it goes inside and that's why that blockage can occur. But in this electrode it is used for so many times, that's why it is not possible. Che biju?
And when does it go to scala vestibuli also? Sometimes it slips into the scala vestibuli.
Scala vestibuli it start at the oval window. Scala vestibuli is diverticulum of the perilymphatic system at the level of oval window and we are inserting electrode from the round window, elevating the membrane, exposing the round window aperture little bit around 1.1 or 1.2 millimeter. If in case of metal it required 1.3 millimeter. In case of cochlear we don't require that much of exposure in scala tympani, so we don't require that much bone removal. With round window membrane removal or we are dissecting the round window and we can insert the electrodes very easily. Che? I will try, if it is possible I can do. Yes, whether this electrode can go inside the scala vestibuli, yes, it can go. When the direction of electrode is not towards the floor of scala tympani, we have to follow the cochlear duct pathway and for that we have to insert our electrode that this way, see. Yes. If it does not go more than this, I will not push it. See, it does. Okay. So this is the rim, white rim you can see.
At the level of PT and first ring at the level of.
So it should go up to here only. But if it is kink this way, we don't have to push inside the scala tympana. For inner ear anatomy, we required one more lecture. I can't explain everything on this at present because we have to complete the dissection also and you have to start your dissection. So this way we have to insert our electrode close to the floor of scala tympana. Yes, definitely 100% we have to take care. It will not go towards the scala vestibular or it cannot rupture the basilar membrane. Both the things we have to take care. So this is posterior tympanotomy approach. I little bit wide the posterior epitympanum, then I will give next session to કેટલા વાગ્યા છે 12 વાગ્યા છે Ossiculoplasty. You have to finish it fast, so I will from canal wall up to canal wall down it will not take too much time, but Dr. Devang will show grommet is not possible in this rupture membrane, but he will show some ossiculoplasty. Yes. This is specifically I am exposing for the resident. Sister Nani Barjoy sir. Because if you see middle ear cavity or middle Nani bar.
Any queries till now? Any structure identification, why, where,
हेवी नहीं हो
what?
गया ना? मानवी को पूछ रही हूँ. It's not too much. है ना मानवी? मैडम? ठीक है?
It's not too much, it is just adequate.
Okay. So basically when we define specifically for the third year and SR who is coming from the medical college, I will define it each and every canal wall up, canal wall down, buttress again. But before that I want to show you how middle ear cleft. Middle ear cleft means from the eustachian tube to the sinodural angle, mastoid tip, dural plate as well as antrum. If you see entire medial wall of the middle ear cleft with content, how it looks like. So it is very much essential that one has to see ossicles transcanal through the mastoid above the scutum, so they can visualize three-dimensionally how these ossicles looks in epitympanum. આનાથી એક નાનકડી બત તૈયાર રાખજો.
When there is a drilling, madam is drilling, the important thing to be noticed is she is drilling from below up, right? From more vital structures to the non-vital structure, not from upside down.
So always we have to remove the bone from important structure to less dangerous area. હવે એક નાની બર આપજો. સિસ્ટર આ બર બહુ ચાલતી નથી. I will preserve my superior bony meatal wall. I have to. Okay. So we can do inside out also. Inside out technique. Now you can see both the superior aspect of the both ossicles with some fold anteriorly.
Malleolar fold, madam?
Yes. Now clear?
Yes.
Yes?
Yeah.
Okay. Now again we will see from here. See. Why I am showing you this thing? Anyone? So now you can realize the relation of mastoid antrum in relation to middle ear cavity as well as external auditory canal. This one is external auditory canal posterior aspect. Here there is a spine of Henle and posterior superior to it lies the antrum. So this antrum, editus and attic, it always lies superior to superior bony meatal wall, and that's why part of pars flaccida we are removing, part of tympanic membrane pars flaccida we are exposing, and part of the scutum. That means scutum is this is scutum. So we have to remove this part so we can directly enter into the epitympanum. So this is another way to go to the epitympanum. If disease is in the Prusak space, what is Prusak space? The space between the neck of malleus and malleolar fold and pars flaccida. If Prusak space disease is only there and all ossicular chain are intact normal, disease is very limited, you can remove part of the scutum, you remove the disease, you visualize the ossicles whether there is any disease medial to these ossicles, and then you can cover the scutum defect with cartilage and you can give intact ossicular chain canal wall up surgery for the cholesteatoma. But in this surgery always advise or always keep close follow-up to the 6 month and 1 year, because if there is some residual or some recurrent disease, then you can, if there is some cholesteatoma flex over the very vital structures like oval window, like facial nerve, like dura or sinus, where you cannot remove this cholesteatoma flex. at that time we have to perform even on the lateral semicircular canal fistula. We have to cover it out with the grafting. We have to perform the canal wall down procedure. We have to keep observation for the 6 months or 1 year. This left out cholesteatoma will convert it into the pearl formation, which is easy to remove after 6 months or 1 year follow-up in second stage surgery. So if you are not confident to remove disease from the facial nerve, dura, sinus, stapes, oval window, even round window, sinus tympani, keep it there, keep close observation, canal wall down procedure only, canal wall down. Then if there is a posterior bony meatal wall, you cannot keep your eye on the lateral semicircular canal or dura or sinus. For that you have to perform the canal wall down surgery. Any unresectable cholesteatoma, one has to perform canal wall down surgery, because we have to follow these patients for lifetime for the recurrence. And literature says it is 5 to 21% of recurrence even in canal wall down. Because of this cholesteatoma flags attached to the some very vital structures, and we left it because of some or other reason. Now, I have already ભાઈ ઓસિક્લોપ્લાસ્ટી માટે તૈયાર? So I will repeat every surgery again and how I can convert this canal wall up into canal wall down. Now I have to remove only one posterior bony meatal wall from here to here. So that is canal wall down. I have to just remove this one wall only. So this is facial bridge. This part is facial bridge, which lies over the horizontal facial nerve. Anterior buttress and posterior buttress is part of the bone which lies between the anterior posterior tympanic spine to tegmental plate, and the bone which inferiorly attached to the floor of the external auditory canal, that we have to remove. In this way we will convert into the canal wall down. So in case of pediatric patient, in case of demanding patient, in case of patient who are swimmer or who tell no I can't keep, so give one trial. But when you will give one trial of canal wall up, when there is no LSC fistula, if cholesteatoma is attached to the LSC, stapes, sinus or dura, you have to keep close observation over these structures, and for that you have to do canal wall down. But if there is a limited cholesteatoma and you are quite confident that you have removed each and every cells, diseased cell along with the cholesteatoma, you can keep the canal wall up, keep good observation, follow up for at least 1 to 1.5 years. So this recurrence, and for resident, what is the motive of surgery, cholesteatoma surgery? One is dry ear, second is safe ear, third is functioning ear, and fourth is self-cleaning. So main thing is safe, dry, self-cleaning, and fourth is functioning. If it is dry and safe, you can reconstruct in second stage. Clear? Okay. So we have done first canal plasty to remove or expose the annulus all around, one thing. Second, then we have performed cortical Devang kya chhe? Devang, ossiculoplasty. Second is cortical mastoidectomy. In cortical mastoidectomy, external landmark is superior temporal line, posterior bony meatal wall, and line joining to it. That is surface landmark. We have only 15 minutes. Then I have to do canal wall down. Yes. And cortical mastoidectomy, we have surface landmark, superior temporal, posterior bony meatal wall and sigmoid sinus. At the level of antrum, when we can say this is cortical mastoidectomy is complete, we can see the mastoid tip, sinodural angle, and in antrum, if you can see short process of incus without injuring it, it's good, but LSC is enough for the cortical mastoidectomy. Now for posterior epitympanotomy, when we complete the cortical mastoidectomy, we have to remove the bone lateral to LSC, and between the tegmen and second genu. I am clear? In epitympanum and editus, we are going from mastoid to epitympanum. Upper superior is tegment, inferior is second genu facial now, lateral attic wall, medial attic wall, in between the ossicle. So we are removing the lateral wall. Try to keep ossicular chain proper. If you feel you are not confident, you have to disarticulate the IS joint. You can see incus, body of incus, short process of incus and incudal buttress. This is the good posterior epitympanotomy. Posterior epitympanotomy is one procedure through which we can visualize epitympanum, attic region from the mastoid. Now after that we have done તારે જે કરવું હોય ને એ બોન કરજે હો બોન ઉપર ના we don't have time. After that, identification of vertical segment of the facial nerve. Now for the identification of the facial nerve, we have to identify two things: lateral semicircular canal, yes, but entire lateral semicircular canal and anterior aspect of lateral semicircular. Then and then you can see short process of incus. Now I am clear? So LSC is like this and short process of incus like this. In reference to these two structure, we have to thin out our posterior bony meatal wall without perforating it. So we have to use 3 mm size of diamond burr. For vertical segment of facial nerve, we have to dissect from the inferior aspect of the lateral semicircular canal at the level of incudal buttress. I think incudal buttress is quite clear.
Yes, ma'am.
From incudal buttress, we have to create horizontal path from LSC to the mastoid tip. Why? Because it is probable site of the vertical facial nerve. With this dissection, we have to identify chorda and facial and facial recess area. After that, we have to perform the posterior tympanotomy without injuring chorda and facial. How we can do? We have to use 2 or 2.3 mm of burr. If you have narrow facial recess, you can use 1.8 mm of diamond burr. We have to go layer wise, never directly go and injure the stapes or round window or facial nerve. Through the posterior tympanotomy, you can see the structure of retrotympanum.
Yes, sir.
Clear? Now, almost we have separate our vertical segment of facial nerve posteriorly. So we can visualize very well. In live patients, we don't have to dissect this much deeply. We can visualize vessels over the facial nerve. And after that, as our posterior bony meatal wall, so canal wall down is removal of posterior bony meatal wall. What is canal wall down? Removal of posterior bony meatal wall. By that way, you are creating two. You have two cavity. One is middle ear cavity, other is mastoid cavity. You are creating two cavity to identify the disease in the middle ear cleft from eustachian tube to the mastoid tip. You have seen both entire area. Now you feel There are lot of cholesteatoma, dura, LSC or very vital structure. You want to convert this canal wall up into canal wall down. As you have thin out the posterior bony meatal wall. It is quite anterior to the facial now. It was quite anterior to facial. But it is very easy to remove entire posterior bony meatal wall for the canal wall down. That is last we will do. Center kari de.
Thank you, ma'am.
Dr. Neena, can I ask one question regarding the indication of posterior tympanotomy? From all practical purposes, of course, residents are, they are known to all the genuine indication. The inside out techniques are very popular now. So the posterior tympanotomies are, except cochlear implant, we don't do, isn't it?
We don't have to do facial recess approach in every patient of cholesteatoma. First thing. Why we want to identify the facial now? Because we are always worried about the facial now. At which level we have to remove the posterior bony meatal wall? At up to what level we have to drill it down so facial reach is adequate? Lower down. For that also identification of facial now is required. Now posterior tympanotomy, if you don't want to do posterior tympanotomy, it's okay. But if disease is present in sinus tympani, facial recess, that sinus tympani disease we can remove from the transcanal with the angular instrument and endoscope. But for the facial recess disease, we have to expose the facial recess, the area between the facial and chorda. For canal wall down, identification of facial nerve is required, because only fear of facial nerve leads to facial nerve palsy, not the identification of facial nerve leads to facial nerve palsy. Because once facial nerve is in front of you, you will go anterior to it. You will remove the posterior bony meatal wall because it is anterior. You very well remove the posterior bony meatal wall. Even floor of the external auditory canal also you can make it lowered, because facial nerve is in front of you. So that is the reason identification of facial nerve, horizontal, second genu, and whenever we have to remove the disease from the second genu, we have to remove the bone from the anterior aspect of the lateral semicircular canal, because that facial nerve goes inside and this posterior bony meatal wall is attached to it. In that case, we have to expose this area. If we know our diamond burr is close to second genu and facial nerve, it is removing bone, but it is not touching the facial nerve, we are quite confident to remove disease from all this area. So, कभी ना कभी तो मैडम करना पड़ेगा. So it is required, but not always posterior tympanotomy is required. Facial nerve identification is required. Dehiscent facial canal, yes. Again, whenever you are dehiscent facial canal seen mainly in horizontal facial nerve at the level of second genu. If cholesteatoma is in the anti-epitympanum, then in the geniculate ganglion. So these are the most area where the facial nerve is dehiscent because of disease, because of lack of ossification. These two things are there. So for that, whenever we are opening, we are clearing the disease from the middle ear cavity as well anterior epitympanum. Always we have to dissect the disease with help of cottonoids and not sharp instrument. Blunt instrument, we have to just elevate the cholesteatoma sac. First we have to remove the underlying matrix. If you want to see how this scissors here, how this cholesteatoma enter into the middle ear cleft, scissor આપો. ના 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 તો તું તારું કામ પતા વાંધો નહીં. So this is finger glow. Now what is cholesteatoma? How it, if you see posterior superior or atic cholesteatoma, it's like this. There is a retraction of skin. So this is normal. Now I am folding it to this way. So this is atic retraction pocket or posterior superior retraction pocket. Now from here, this sac is going towards the different region of middle ear cleft, but this part is filled with the matrix, cholesteatoma matrix.
Yes, ma'am.
Okay. So whenever we are removing disease, cholesteatoma disease, from the mastoid towards the epitympanum and then mesotympanum, we have to separate it with help of blunt instrument, with help of cottonoids, with help of adrenaline and steroid cottonoids, and slowly we have to move in the direction of that structure. If we are elevating cholesteatoma over the horizontal facial now, we don't have to move perpendicular to it. We have to move in the same line of the facial nerve. Same way, whenever we want to remove disease from the stapes area, again that movement is always posterior to anterior or anterior to posterior, never perpendicular to the crura. Otherwise, all stapes will come out. Clear? But if you see the book, Chambok book is very good book for the postgraduate, and it is given that this glow-like structures, this is the retracted part, and here this is medial wall, lateral wall, inside that matrix is collected. Once you empty this sac is covered over the medial wall of the middle ear cleft. Last structures, the last part of the cholesteatoma sac elevation is lateral semicircular canal. If there is some fistula, if you feel like that, then you have to cover it with your grafting material, or sometimes you have to take some additional precaution to elevate from the lateral semicircular canal.
Thank you, ma'am, for external demonstration and all the beautiful bookies picture, ma'am. Thank you, ma'am.
It is type 1 tympanoplasty. It is same as myringoplasty. Hello.
Remaining of tympanic membrane from the lateral process of the malleus up to the umbo. So two side, lateral process and umbo, there is a stick attachment. In between this area, you can find plane between the tympanic membrane and malleus. So you can elevate it easily. Difficulty is because there is a formation of bony kind periosteal attachment over the umbo.
So type 1 you understand, right? Then type 2 is again divided into type 2A, type 2B and type 2C. Type 2A is there is some destruction of the lenticular process, but it is covered by the mucosa, and that's why the integrity of the incurdo stapedial joint is anatomically correct and physiologically you are getting the round window reflex. That is type 2A. Type 2B means any reconstruction from the stapes suprastructure to the handle of malleus, that is in relation with the handle of malleus. And when we are doing any reconstruction from the stapes suprastructure not in relation with the malleus is type 2C. Okay? So there are different modalities or different options available for type 2B and 2C. When there is some destruction or necrosis of ossicular chain, this is absolutely intact. I have just dislocated the IS joint from the incus lenticular process and the stapes suprastructure. When there is some necrosis of lenticular and some necrosis of long process of incus, we can have a periosteum to be taken from the mastoid cortex and So when we have some destruction of the lenticular and or the long process, we can do arthrodesis or the arthroplasty by the periosteum between the stapes suprastructure and the eroded part or the remaining part of the long process. So we can drape the periosteum like this. Okay? We can drape the periosteum like this. That is called as an arthrodesis or arthroplasty. Why periosteum? Why not perichondrium? Because periosteum leads to development or the maturation of the osteoblast later on, and this incudostapedial joint will be as normal as it should be, maintaining the anatomical and the physiological integrity.
Yes, sir.
However, we have experience and published the paper which states the result in long term down the line 7 to 10 years, not more than 85 or 83%. Another modality, when there is a necrosis of the lenticular process or some part of the long process, is to put a glass ionomer. Glass ionomer between this stapes suprastructure and the remaining part of the long process. Glass ionomer is a powder of aluminosilicate, fluoroaluminosilicate, and the liquid is polyacrylic acid. After applying between the stapes suprastructure and the long process, it becomes a very hard and solid joint here. Okay? It forms the very hard and the solid joint resembling the normal IS joint anatomically. But the long term results, because of the fixation, it is not resilient as it should be the IS joint. Okay? It is anatomically fixed joint. So the long term results in case of using the glass ionomer down the line 7 to 10 years is not more than 80%. So we have stopped using that. Another option is when there is a long process or some part of the lenticular process necrosis, we can put cartilage between the stapes suprastructure and the remnant of the long process. That is type 2C. Okay? It is independent of malleus. That's why it is type 2C. And when we are putting a cartilage from stapes suprastructure to the underneath the malleus, the Y-shaped cartilage, the long axis of the Y-shape is resting on the stapes suprastructure and the flanges going underneath the long process, handle of malleus, it is type 2B because it is in relation with the handle of malleus and the stapes suprastructure. Okay? So this is all about type 2 tympanoplasty, and the long term results by using the cartilage with perichondrium is very encouraging, and it gives nearly more than 92% results in the follow up of more than 10 years. Now another modality is when there is no incus, no malleus. Okay? So in that case, you have to make a small fenestra or a pit in the anterior canal wall, small fenestra or a pit in the anterior canal wall at the level just above the annulus, and put a cartilage bow. Okay? The boomerang bow of the cartilage right from the stapes suprastructure to the anterior canal wall. And here on the stapes suprastructure, we put a fenestra, small acetabulum, for this stapes suprastructure to accommodate in the cartilage we are keeping over the suprastructure. Okay? So that reconstruction will be like from stapes suprastructure to the anterior canal wall, just at the level of annulus or just above the level of annulus. This kind of assembly in the long term, 10 year down the line, gives more than 94-95% results, condition provided that we have preserved the perichondrium of cartilage on both sides, the superior side and the inferior side. Okay? None of the sides should be bare of the cartilage because the perichondrium provides the nutrition or nourishment for the cartilage to go or to stay in a long duration. Now another modality is to put a simple grommet over the stapes suprastructure or the PORP. We have to tailor-made the PORP, that is partial ossicular reconstruction prosthesis, depending upon the height of middle ear, what we want to achieve.
Sir, fine focus and centralization.
So, kache?
Focus, sir.
Okay. Better?
Better.
So this is a PORP, and the material what is used for making the PORP is Teflon, or we can have titanium. Okay? Oh. It's not happening. Yeah. So this is because the Teflon is not that good, and we have used in some 50 patients Teflon, but because of this difficulty and accidental migration of Teflon after the reconstruction, we have stopped using Teflon. So we have used titanium prosthesis as well, and the recurrence or the, sorry, not recurrence, it's an accidental extrusion rate with the titanium PORP is also same. Down the line, more than 7 to 10 year experience, we have extrusion rate of 14 to 44%, even if we are using interposition of cartilage between the graft and the PORP or TORP capped. This Teflon is not working well probably. Yeah, this is positioned, and we have to put a cartilage on the top of PORP before grafting the middle ear, okay? So as to prevent accidental extrusion. However, whatever precautions we have kept and interposed cartilage, the accidental extrusion or the extrusion in the postoperative follow-up is not less than 14 to 44. So that is a very discouraging, and that's why we have stopped using PORP. Either it is a Teflon or the titanium. So the question remains,
which is recommended from our side, the recommended ossicular reconstruction. Believe me, it is from the stapes suprastructure to the anterior canal wall. The boomerang, it is the best in the long-term follow-up. Results in our hands are more than 92% of 10-year follow-up. Okay? So,
Yes, sir.
madam, suprastructure કાઢતો નથી, બરાબર ને? So, another situation is when the patient is not having stapes suprastructure. Okay, here you can see this is incus.
So fine focus.
Is it?
Yes, sir. Better.
So here you can see this is suprastructure. This is incus. So condition is there. There is no incus. There is no suprastructure. Here you can see the oval window. Can you see this oval
Yes, sir.
window?
Yes, sir.
So the condition in which there is only oval window with or without handle of malleus. In that particular case, we put a torp directly onto the foot plate. Okay, and on the top of the torp, we have to interpose the cartilage before putting the temporalis fascia graft. Okay, so as to achieve the proper middle ear height. Can you understand? This
Yes,
is
sir.
foot plate, and on the top of the foot plate, we are using the torp. I will try to put the torp, but it seems difficult because we are not removing this suprastructure. I will try to show. ચાલો દો ને તો ડિસલોકેટ થઈ જશે. ઓકે, yeah. Okay, so one option when there is only stapes foot plate is a torp. Either it is a Teflon, which is not recommended because the extrusion rates are very high. Then another is a titanium. The cost factor is of course important because the titanium costs 10.5 to 11K, and which is important for us when we are doing the reconstruction because we have to identify the cost benefit ratio. The another important modality what we are using for reconstruction in this kind of scenario is to put a boomerang, the cartilage from the stapes foot plate to the anterior canal wall. Okay,
Yes, sir.
just at the level of annulus, like this, and then put a temporalis fascia on the top of it. That is called as a augmentation type 4
Type 4
tympanoplasty.
diplasty.
Okay,
sir.
anything on the foot plate is type 4, anything on the suprastructure is type 3. Got it? Atlu adequate.
Thank you, sir.
Yeah. તો કોણ માઇક કાઢે આપજો ને બેટા? એક મિનિટ.
Which cartilage do you prefer?
Devang, sir.
હા હું આપું છું.
Pick.
So what symptom happens when you say it's a perichondritis in that graft happened? No, in the conchal. How does patient complains that he has developed? Perichondritis of pinna, or I mean that graft we have kept, and I thought that portion, the graft you have kept inside the middle layer. No. Okay.
Canal wall down up છે. So again, I am audible? Okay. Not? Yes? Okay. So I have already done cortical, posterior tympanotomy, posterior epitympanotomy, identification of vertical segment, and this is nothing but canal wall up. Canal wall up. But madam is asking for inside out. If we want to do inside out, one thing. And second thing, how to convert this canal wall up into canal wall down. So first I will remove the scutum for the inside out technique. So picture is clear?
Yes.
Yes. So this is medial aspect of the posterior bony meatal at the level of annulus. Okay, now picture is clear. I want to show you where I want to dissect it. So I magnified little bit. We don't have to touch ossicles. So how to remove this scutum? That is most important. Posterior superior region bony removal as well as removal of scutum. Suction, ear suction. આની કરતાં એક મોટી બર. So again we have to drill from medial to lateral always. While doing removal of scutum or removal of lateral atic wall, we have to take care of tegment tympani. Picture is clear? Center nahi hai. Okay. You can see the lateral process of malleus with handle.
Yes.
So this way we have to remove the lateral atic wall for aticotomy, limited aticotomy. આની કરતાં મોટી બરાબર છે પછી આ લઈશ. Whenever we are doing dissection very close to important structure, we don't have to remove it too fast. So it can touch to ossicular chain or chorda tympani. Anyone, any question? Resident?
And center. Okay. Yes.
because incus is manipulated, it will come into So when we remove the part of the scutum, neck of the malleus is exposed, and that is the part of the Prushak space, first part where the cholesteatoma arises. When limited cholesteatoma, you have to remove the part of the scutum, not entire scutum. નાની બરાબર નાની 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 picture is clear there? You can see lateral process is closely towards the anterior wall, and that is the main thing which obstruct the view of anterior annulus many a time, and that's why we in so many patients we have to do anterior canal wall plasty. Here this displacement is occurred due to manipulation of ossicles, because it is now open from the superior side, and that's why it comes into the view of in patients. It does not come forward when we are remove the scutum. We can easily remove this scutum inside out in technique with preservation of ossicular chain. Now I will focus over the neck of malleus. Picture is clear there? This is lateral process.
Yes.
Okay, and this is neck of malleus.
Yes.
So structure at the neck of malleus, it forms the medial boundary of the Prushak space. So between the neck of malleus and pars flaccida, as you elevate the pars flaccida, this structure Prushak space is very easily seen. But if you see cholesteatoma invade superiorly into the atic region, then you have to remove the scutum. Okay. Now you can see there is a partial removal of scutum, through which we can see the ossicles, and we can decide that we have to remove entire scutum or not, lateral atic wall or not. That we can decide from not only from the CT scan but also from the okay. Now I want to show how we have to convert the canal wall up into the canal wall down. Yes, now entire picture is seen.
Yes.
What we have to remove, first year, second year, third year, what is canal wall down? canal wall down is surgically debride the disease from the middle ear cavity, from the epitympanum, from the editors and from the mastoid air cell system. First thing. So debridement of disease from the entire mastoid cells lateral to the aortic capsule. Lateral to the aortic capsule. Now we have middle ear cavity including epitympanum and we have mastoid cavity. But certain disease which is very much infiltrating to the vital structure like LSC or facial nerve, second genu or sinus or dura, we want to observe our surgery outcome from the canal with help of otoscope. Whether we can visualize LSC, yes, we can visualize LSC after removal of posterior bony meatal wall. Okay, so that we have to remove. Now, if I have not identified the facial nerve, if I have not identified the facial nerve, from which level I have to go down at the facial ridge, it is not perfectly I can say when I remove the posterior bony meatal wall. But once I identify the lateral anteriormost aspect of LSC, short process if present, short process of incus, incudal buttress, and you don't have to reach up to facial nerve, but if you find out the pathway, then you can thin out the posterior bony meatal wall. So that is the probable site of the facial nerve. And anterior to that facial nerve, you can remove the posterior bony meatal wall very easily, even at the medial level. We are not talking about the lateral level. And that's why facial nerve identification is very important at the medial level. So,
one question, ma'am. Ma'am, how can we address sinus tympani at this point of time?
Sinus
can we or
tympani.
can we not? That is also.
yes, sinus tympani both way. If you see posterior tympanotomy, what is sinus tympanotomy? Sinus tympanum. It is area between the promontory and facial nerve, vertical segment, ponticulus and sabiculum, between the lateral wall and medial wall of. So this is exposed. This sinus tympani we can delete from posterior tympanotomy. If we have not performed posterior tympanotomy, we have to remove little bit, we have to widen the canal plasty. So we can see oval window and round window properly, and then we can remove the sinus tympani disease with angular instrument beneath through the canal like this. Angle वालों कोई भी आपको. This is structure is possible to see there? Yes. So this is sinus tympani, this structure. This, so disease removed from here is very easy. That is from the sabiculum and ponticulus. But sabiculum and ponticulus is visible after removal of canal wall down in here, in cadaver. Yes. So, use of large burr. This is another method of inside out. We have to remove the lateral atic wall as well as scutum. Incus. I will keep. Don't worry. No. छोड़ दे. Okay. So now you can see I have removed almost posterior bony meatal wall. Still I have to do something else. What? This is floor of external auditory canal that I have to lower down. Ani kata nani. When facial nerve is very much visualized, we don't have to worry about canal wall down. Now I am removing the anterior buttress. I will show you with very small bar. 1 mm में अब हाँ only one or two. Picture is clear there. This is anterior tympanic spine. Yes.
Yes.
Yes. Still there is a structures. This bone that we have to remove it. કઈ કામ છે? So smallest bar is required for removal of the anterior buttress. Then and then we can see two structures, anterior epitympanic recess with supratubal recess. What is supratubal recess? Anyone? Supratubal recess. Supratubal recess is part of anterior mesotympanum. Part of the anterior mesotympanum. It extends superiorly towards the epitympanum, anterior epitympanum. So basically it is part of anterior mesotympanum. Supratubal recess is part of mesotympan, but it extends towards the anterior epitympanum. And floor of supratubal recess has a pre-geniculate facial nerve. If you see the floor of supratubal recess, there is a pre-geniculate part. That means if horizontal is going from the oval window over the cochleaformis process, then it reaches up to the geniculate ganglion. Before geniculate part is situated in the supratubal recess. So the structures were many a times, because of anterior epitympanic cholesteatoma, this part of the facial nerve is dehiscent. Okay. So first I have already done canal wall down. To reach exactly in anterior epitympanum, I have to remove head of malleus. Okay, bone nibbler, malleus nibbler છે sister? Even if we are doing from the posterior epitympanotomy, many a times because of cholesteatoma, the atic cavity is many a times eroded and wide. If we want to see anterior epitympanum through the posterior epitympanum, we have to remove the head of malleus. So for use of malleus nibbler, we have to first, yes. Okay. Always keep handle of malleus for the middle ear space. Whenever we want to drill upon, yes. Whenever we want to do cavity tympanoplasty, always preserve handle of malleus. And handle of malleus is last structures which involve in cholesteatoma. So I am now removing the anterior buttress, so we can visualize supratubal recess as well as anterior epitympanic recess as well as cog. Here, when our canal wall down is properly done, when our wall of anterior epitympanum and wall of mesotympanum in a one layer, this way, then and then you can say your cavity is proper. So you can see this is straight, but some bone is here. So I will remove this. Now we will magnify incus lay lo hobe, and will identify the structures of epitympanum layer wise, one by one.
Hello, Dr. Neena.
Yes.
Any vital structure in the anterior epitympanum we should be aware of? Sometimes there's a lot of bleeding. And vital structures while drilling the anterior epitympanum?
Only if we want to align anterior epitympanic anterior wall of mesotympanum in one line as a proper cavity. If we drill, we have to take care regarding the TM joint only, laterally. Okay. So in this anterior aspect, we have to take care of TM joint only. If our burr is touched to the medial wall of the anti-epitympanum, then facial nerve can injured in anterior epitympanic as well as supratubal recess. Because pregeniculate part of facial nerve is situated in the floor of supratubal recess. From there it will go to the geniculate ganglion towards the tegmen, and then it go posteriorly. I will show you. I want to magnify it, and I will
fine
show.
focus.
Yes, yes, yes. હું બધું જ કરીને બતાવું. Just I want some time.
Yes, ma'am.
Okay. Okay. So this is handle of Malleus. Okay. First thing, this is handle of Malleus. It is separated from the. This is cochlea formis process with red color tensor tympani muscle. Okay.
Yes.
This red color is tensor tympani muscle, and this is cochlea formis process. Let me see. This is the very important structures I have to show you by any way. So this part where the tensor tympani is attached is cochlea formis process. One thing, cochlea formis process is landmark for the horizontal facial nerve. So this is horizontal facial nerve. Okay, clear? So this one is horizontal facial nerve. It goes, this is LSC. It goes anterior and inferior, anterior and inferior. So it goes like this, this and here. If you touch this, you can see the movement of facial nerve. So this part of area, many a time it is dehiscent, and when you are doing stapes, so you have to take care your Teflon is not touched to this inferior part of the facial nerve above the oval window, superior to oval window. So here it is visualized or not?
Yes, ma'am, it is visualized.
Yes. Now in reference to I want to show you the cog. Madam was asking about the cog, and that's why I am magnifying it. So cog is always parallel, always parallel. Remember it. This is cochlea formis process. See, this one is cochlea formis process, and above it this is cog. This is cog. Sister, ekdam nanakdi bar apo. Once I remove this cog, I will enter into anterior epitympanic recess. So cog is demarcated bone from the tegment which separate the anterior and posterior epitympanum. It is visible there, this bone?
Yes, yes.
Okay. Now it is clear?
Yes.
Okay. Pakdo. This is posterior epitympanum. This region, this bone is cog. So once I remove this cog, we will continue this. Anterior and posterior epitympanum. Why anterior epitympanum is known as anterior epitympanic recess, you will realize. Okay. So one fossa is seen. Deep recess. This is deep recess. This is anti-epitympanum. This entire. And that's why whenever there is a cholesteatoma which is present anterior to head of malleus, and if cog is present, if disease is not that much severe that cog is already eroded by the cholesteatoma, then this cog cover, first it demarcate between anterior and posterior epitympan, but it also hide the cholesteatoma of anterior epitympanic recess behind this intact cog. And that's why on tegment plate, we have to make it very straight plate. We have to remove this cog, so we can reach up to anterior epitympanic recess. Its recess is always deep inside, and then supratubal recess. These are two structures which is many a time hide by the cog. So make a continuous epitympanic cavity, we have to remove the cog. Why our cholesteatoma disease is reoccur, or why it is residual? Because there are some areas which is hidden, like scala tympani, facial recess, anti-epitympanic recess, supratubal recess. These are the beneath the anterior buttress. These are the structure where you can find the cholesteatoma, and we miss that, and that's why there is a residual or recurrence cholesteatoma even though there is a canal wall down. Cog always in straight line of cochleaformis process as well as lesser petrogel now. Now you can see one fold which is also known as tensor tympani fold. It lies between anti-epitympanic recess and supratubal recess. I will show you. This is anti-epitympanic recess, and this part is tensor tympani fold. I have to remove this. Then I will find the supratubal recess. Now you can see the supratubal recess. So this is picture is clear there?
Yes.
Okay. So we have big posterior epitympanum, very small anterior epitympanum, very small supratubal recess in compared to the posterior epitympanum, and we usually forget to remove this cog. You can see cog is very pneumatized bone. We can't even identify as a cog. But if you see from the cochleaformis process, exit at the same level on the tegment tympani, it is demarcated bone which separate the posterior and anti-epitympanum, and each and every bone will show you cog because these are the normal bone. You will find out the cog as well as supratubal recess. So for resident again, what is canal wall down? Canal wall down is exteriorize the disease from the entire middle ear cleft, removal of posterior bony meatal wall in such a way that mastoid cavity as well as middle ear cavity will drain out into the external auditory canal. So that is the exteriorization of the mastoid as well as middle ear cavity, which is known as modified radical mastoidectomy. So this is modified radical mastoid. Still we have to remove this lateral bone, this bone. Okay. So we have already keep ready your bone, everything. Just before lunch, I will not allow you to do lunch before doing something on the bone. So first you will do or start how to dissect in the bone, and after that at 2 o'clock you will take lunch. Otherwise in sleep you might sleep our birth. Yes, yes, madam. Yes, I will show you.
Also, ma'am, if you can show all the landmarks for facial now.
Yes.
All the pointers.
So now this is canal wall down, entire canal wall down. Procedure is completed. Socialization is done, and last point is meatoplasty. So with help of pointer, I have to yes. મને આપજો ને પોઈન્ટર કોની પાસે છે લે આ પકડજો. So this is my anterior wall of epitympanum and anterior wall of mesotympanum should be in one line. First thing, this mastoid tip is deeper than the canal. If it is disease is present and we are doing canal wall down, always do obliterate with muscle, with bone dust, with whatever material you have preserved for it. Second thing, now we have already identified vertical segment of facial now in mastoid dissection. But if we want to identify from the canal wall down mastoidectomy, we have to start with this is cochleaformis process. This red looking structure is tensor tympani muscle, part of it, because I have removed the malleus. This is broken. Okay, this is round window, this one is promontory. In your bone you will see from promontory towards the cochleaformis, from promontory towards the cochleaformis process you will see lesser petrosal now definitely. Okay, it goes like this, same direction, and from cochleaformis process towards the tegmen you will find same this level only, Cog always demarcate between the anterior and posterior epitympanum. It is small on anterior epitympanum, large posterior epitympanum, because in posterior epitympanum head and body two ossicles are situated. Now our facial now, this facial now is it going up. This one is LSC. Pointer थी बताइए in microscope. So first we have to identify the LSC. So this is LSC, entire LSC. Okay. Anteroinferior, this one is, see this, you can see the movement of facial now. See, this is second geno. Clear? It is usually this site, usually facial now is dehiscent, and the most common cause of facial now paresis, traumatic, surgically traumatic or disease wise, is second genu and this part of the facial now. Now from vertical segment you can see this is vertical segment, it's second genu. You can see the movement of the facial now. It goes superomedial to the cochleaformis process, superomedial to the this cochlea formis process. So from there it goes to the anterior epitympanum in the floor of supratubal recess. Okay. Always pneumatization define this epitympanum, supratubal recess, mastoidectomy. If there is a good pneumatization, you can identify these structures very well. If there is a less pneumatization, epitympanic fixation, some other reason, genetic or environmental, these structures is not that much well defined. But almost in all cases, you can see anterior epitympanic recess as a bowl. If you see, it looks like ball. It is always anterior to the cog and it is hidden by cog. Even cog is partially eroded, but this epitympanic region is usually hidden, and that's why we are missing out the cholesteatoma to remove from that region. So if you treat one cholesteatoma, after 1 week you treat another cholesteatoma, everything is different. Disease may progress anteriorly, posteriorly, medially, towards the petrous apex, towards the ET tube, anything can happen. So never ever any cholesteatoma is alike. They all are different, and many a times that's why drill dissection is different in every cholesteatoma. But yes, canal wall down, facial now identification of structures are same. We have to remove the diseased cell, supralabyrinthine, infralabyrinthine, supracochlear, infracochlear, according to invasion of the disease. So you can see pink color is facial now. So if we say superior semicircular canal, labyrinthine segment is related. Labyrinthine segment is antro-superior to the superior semicircular canal. Horizontal facial now and second genu is antro-inferior to lateral semicircular canal, and vertical segment of facial now is lateral to ampullary end of posterior semicircular canal. So facial now has a relation with cochlea, vestibule and semicircular canal. Our basal turn of cochlea is, first turn is move like this. Here medially facial now is also related. So if we move from promontory towards the medial side, this is theoretical aspect, we don't have to see in disease, but basal turn of cochlea is medially is related to the facial now. Barabar? So facial now is situated in bone of petrous bone, otic capsule also situated in the petrous bone. Development of otic capsule and facial now are associated with each other, and that's why any congenital anomaly of otic capsule will lead to variation in facial nerve pathway. And it is why it is seen mostly in congenital anomaly of otic capsule in deafness patients, and that we have seen all the facial nerve variation more in the pediatric patients or deaf patients. So facial nerve always lies in the medial wall of the middle ear. It has relation with vestibule. It lies superior to the oval window. It lies posterior to the oval window at the second genu. Clear? So this pink structure, this is oval window, and facial nerve is here. So superior to the oval window here and posterior to it. So this is the relation of facial nerve. Then we have to still dissect the labyrinthine segment, but today we will not do. We will do tomorrow. Before that you have to complete in your bone canalplasty, identification of structure, cortical mastoidectomy, posterior epitympantomy, and basically how to use drill, how to use suction how to move on the bone. That is the most important thing in these 2 days. What to remove, how to remove, as your patient will always teach day by day. But how to use each and every structure, microscope, drill, handpiece, suction, how much irrigation, where less irrigations, if you are dissecting over the facial now, how much pressure, and when you feel this is enough dissection, everything you will learn here in cadaveric bone. So feel free, but just take care. We don't have to dissect LSC today only. We will dissect LSC skeletonization as well as translabyrinthectomy tomorrow. So preserve as much as structure possible. And if you don't understand, or if you feel that what we should do in this disease or that disease, you can ask during dissection, during these 3 days. We are here only. So, according to name, બધાનું ગોઠવ્યું છે ને? Madam, you come at રહેવા દે. મેડમને જરાક માઇક્રોસ્કોપમાંથી બધા સ્ટ્રક્ચર બતાવો. હા, ખાલી